to all, offering my humble pranams to the lotus feet of His Holiness Dr. Rajendra Mahaswamiji and seeking the blessings of His Holiness Jagadguru Shri Shivaratri Deshikendra Mahaswamiji. I take immense pleasure in welcoming all the dignitaries for this webinar on infection prevention and control practices in healthcare setup. See, especially in a pandemic situation like what we are facing today, infection control practices and strategies to prevent infection has got very much relevance in today's scenario, especially for healthcare professionals who are dealing with infections day in and day out. It becomes even more imperative that they take care of not only the patients, the surroundings, but themselves. So that is where the objective of this webinar is. So on today's occasion, I have the pleasure and the greetings from the officials of JSS Academy of Higher Education and Research, Dr. B. Suresh, Pro-Chancellor Sir, Dr. Surinder Singh, Vice Chancellor Sir, Dr. B. Banjunatha, Registrar Sir, Dr. P. A. Kushalappa, Director Academics, and all other officers from the JSS Academy, to all the resource persons, participants, as well as those who are part of this webinar. First of all, I would like to welcome our Dean, Dr. Colonel Dayananda, Director, JSS Hospital, who has been spearheading this webinar initiative and guiding us in all our activities. Welcome you, sir. I also have the pleasure of welcoming Dr. M.S. Guruswamy, sir, Medical Superintendent, JSS Hospital, Dr. Gori, sir, Deputy Medical Superintendent, and all the other staff from the hospital. Welcome you all. I also have the pleasure of welcoming Dr. M.D. Ravi, Professor Pediatrics and one of the pioneers in infection control practices in JSS Hospital. Welcome you, sir.
Thank you, madam.
I take pleasure in welcoming Dr. Rupa Bhandari, who is here to share with her biomedical waste management in hospital, recent rules and regulation. Welcome you, madam.
Thank you, ma'am.
I also have the pleasure of welcoming Dr. Sanjeev Singh, Medical Superintendent, Amrita School of Medicine, Kochi, who will be delivering his lecture on formulating infection control programs in your hospital based on NABH requirement. Welcome you, sir.
Thank you. Namaskar.
I also welcome Dr. Jayalakshmi, Professor and Head, Department of Microbiology, KMCH Institute of Health Sciences and Research, Coimbatore, who will be delivering her lecture on risk categorizations of areas and procedures in hospital. Welcome you, madam. I now have the pleasure of welcoming Dr. Vandana, Professor and Head, Department of Microbiology, KMC, Manipal, who will be here delivering the lecture on isolation precautions, contact, droplet, and airborne isolation. Welcome you, madam, on behalf of the department and JSS Academy of Higher Education and Research.
Thank you very much.
I have the pleasure of welcoming Dr. Lalu Joseph, Quality Manager at CMC Vellore, and who is also the Secretary General for CAHO, who will be here delivering the lecture on standard precautions. Welcome you, madam. I also have the pleasure of welcoming our important resource person, Dr. Chiranjay Mukhopadhyay, who is Professor and Associate Dean, Department of Microbiology, KMC, Manipal, who is here to deliver the lecture on hand hygiene and monitoring. Does it have any impact on AMR? Welcome you, sir. And at the end of the sessions, we have a panel discussion by all the eminent speakers. So any participants who have got this, any questions regarding any of the sessions, you can post it in the Q&A box. So I also welcome all the participants, the principals and officers of JSS family to this important webinar. Over to you, Kanika.
Thank you, ma'am. I now request Dr. Colonel M. Dayananda, Director, JSS Hospital and Dean Faculty of Management Studies, JSSAHER, to introduce about the webinar. Dr. M. Dayananda is graduated MBBS from JJM Medical College, Karnataka in 1976 and joined the Armed Forces Medical Services in 1977. From there, he served as general physician at various military medical units across the country qualified and obtained master's degree in hospital administration from All India Institute of Medical Sciences in 1993. And he had served in several positions at Armed Medical Corps. From 2012 till 2018, he served as medical superintendent at Kasturba Medical Hospital, Manipal, and chief operating officer for all the teaching hospitals of Manipal University. In 2018, Sir has joined JSS Hospital as the medical director. He is also the Dean of Faculty of Management Studies. His core competencies include hospital planning and consultancy, human resources management and manpower planning, and also has special interest in hospital automation and HIS. With this brief introduction, I request Dr. M. Dayananda sir to kindly introduce about today's webinar. Over to you, sir.
A very good morning to all of you, and special welcome to all the panelists. And in fact, I'm so happy that most, other than Dr. Rupa, almost all the panelists that I have been seeing in the pictures in this virtual meeting are personally known to me. And I can assure and I can vouch that this is the best that we have in Southern India, because all of them are practicing hospital infection control in their hospitals and contributed hugely to the practice of hospital infection control in their hospitals, as well as a lot of achievements and contributions, which many years I have been seeing. I have been following, especially Dr. Sanjeev Singh, Dr. Lalu, and our own chairperson, that's Dr. Ravi. Is wonderful work they have been doing, because hospital-associated infections are one of the bugbears of our hospital, in any hospital that is for that matter. So to address that issue, lot of activities being done in various hospitals, whether NABH accredited, non-NABH accredited, lot of work is going on in a kind of a siloed way. It is not put into the national front because we don't really have the robust statistics to have this, what is our baseline and how we are going to improve is still not materialized even after so many years of practice. However, a lot of work is being done, especially I can see Dr. Sanjeev Singh has been doing, and probably many of you may not be knowing, he's brought at the state level, there was a achievement from his side to see that this kind of practices are trickle down to both private as well as government institutions also. And also in other institutions, they're doing wonderful work in terms of hospital-associated infection. And slowly, what I can see is that there is a perceptible change since I can say 10 to 15 years. There is, in any good recognized hospital, we have a team of hospital consultants with microbiologists, with other people coming around and having a dedicated hospital infection control teams to drive the hospital infection control practices in hospitals. That has been going on, but however, it needs to be more robust, and it has to be done in all the hospitals, not only in large hospitals. To talk on this subject, we have subject experts. We have right from the implementation part, as well as the how to do it in a particular hospital, as well as the last bit of it is the biomedical waste management. How do you dispose it off? And as you can see, as of now, with the COVID pandemic going on, the issues become more acute. How are we going to improve? How are we going to stop this hospital infection from spreading? Because there is so much of uncertainty and fear, even amongst the healthcare professional. So it becomes very, very important to assure them that, yes, by doing this, you will not probably be contracting this kind of a disease or this kind of infection. So with all this in view, our Department of Health Management Studies in our university thought that it is very relevant at this period of time to conduct this topic on this very important topic. And I'm very happy that all the panelists within a short period of time, though it's very, very short, they all accepted and would like to speak on this subject. So not take much of your time. And I'm very happy that all they are there. And I'm sure the webinar we are conducting would be very fruitful to all the practitioners of this thing from different areas, be it the administrators, be it the infection control team, be it the clinicians. It would be certainly be a learning webinar, I must say, that I wish this webinar a great success. And I welcome again all the panelists, and I'm sure they will be contributing a lot during this 1.5 to 2 hours. Thank you very much.
Thank you, sir. Thank you for the brief introduction on today's webinar and emphasizing the importance of infection control practices in the present context. I now welcome Dr. Rupa Bandare to start her session on biomedical waste management in hospital, recent rules and regulations. Dr. Rupa Bandare.
Yeah. Good
She is currently working as a consultant microbiologist and infection control officer, AJ Hospital, Mangalore, also in NABH and NABL standards. Gold medal in MD microbiology, Rajiv Gandhi University and Health Sciences. First runner-up Asian Patient Safety Award for Innovation in Infection Control for 2014 and 15, and also won best paper presentations in various conferences on infection control and biomedical waste management. Her areas of interest are hospital infection control, antimicrobial stewardship, and virology. With a brief introduction, I now welcome Dr. Rupa Bandare to begin her session on biomedical waste management in hospital, recent rules and regulations. Over to you, madam.
Thank you, ma'am. Thank you for the introduction. And good morning, one and all. At the outset, it's my pleasure to be here today. And I would like to thank the organizers to allow me to be a part of this webinar. So with this, I start my presentation. So the topic for me today is biomedical waste management in hospital, the rules, recent rules and regulations. So we start with the story. How did biomedical waste management come into existence? It was in the year 1987. There was a 30-mile garbage slick that was washed off on the shores of some of the beaches in the east coast of USA. And this kind of was a wake-up call for for the world to the issue of biomedical waste management. And from here we started. In the US, the first act was formulated, that is the Medical Waste Tracking Act of 1988. Now, WHO has been also actively contributing to the safe management of waste. The Blue Book, which was designed for the healthcare facilities on management of waste. This was first released in the year 1999. This was further revised in the year 2006. Internationally, there were many conventions on biomedical waste management. One of them is the Basel Convention on Hazardous Waste, which has around 170 member countries, and it is to protect from the adverse effects of hazardous waste. Next is the Stockholm Convention on Persistent Organic Pollutants. This is a global treaty to protect from dioxins and furans. And next is the Minamata's Convention on Mercury. This was held in Japan in the year 2014. This was to phase out the use of mercury-based devices like mercury-based BP apparatus or thermometers from the hospitals. So what was the Indian scenario? In addition to the huge quantum of biomedical waste, we also had a major problem of scavengers. That is, these people would sort out the waste without gloves, without shoes, and also a very major problem of reuse of medical devices without appropriate sterilization. That is majorly the reuse of the syringes. So as an answer to that, India notified the biomedical waste management and handling rules in July 1998 by the then Ministry of Environment and Forest. This provided uniform guidelines and code of practice for safe disposal of waste. So though we were early in formulating these guidelines, what happened next? This was a study which was done almost a decade after that, and this was done by the International Clinical Epidemiology Network. This was done across 20 Indian states, and what they found was that 82% of our primary health sectors, 60% of our secondary health sectors, and 54% of our tertiary healthcare sectors were in the red zone. So what is this red zone? That is, we do not have a credible biomedical waste management system in place. So this opened our eyes to the major problems that we are facing. Further, the Biomedical Waste 1998 rules were amended in the year 2000, 2003. Again, there were some amendments. And in 2011, it was still in draft stage, not finalized due to lack of consensus. And after that, in 2016, Ministry of Environment, Forest and Climate amended the biomedical waste management rules. So what is this BMW Rules 2016 and what were its implications? So the basic, the genesis of this Biomedical Waste Management Rules 2016 is basically divided into 4 schedules. Schedule 1, which speaks about the biomedical waste categorization, segregation, color coding, collection, and disposal. Schedule 2, which states the standard for the treatment and disposal of this waste. Schedule 3, the prescribed authorities and responsibilities. Schedule 4, which includes the labels and the various forms. So we'll move through the Schedule 1. I'll be speaking on the salient changes that were done in these schedules. So the topic, the title itself was changed. In this, the word management also includes handling. Next, the application of these rules. In addition to all the healthcare facilities that generate this waste, collect, receive, store, transport, treat, or dispose the waste, the spectrum was increased to encompass other healthcare facilities as well, like the camps. All healthcare related camps were included in this. And also any biomedical waste that is generated at household level was also included in the gamut of this BMW waste guidelines. The categorization was made simpler. Earlier we had 10 categories, which was, this is I think a boon for many of us to remember the categories. So it was simplified. It was made into 4 major categories, starting with yellow category, which included all the soil waste, the anatomical waste, all the microbiological waste, chemical liquid waste, expired medicines, discarded linen or mattresses. All these things were included in the yellow color code. Next was the red waste, which included all the plastic or the recyclable waste, like the plastic tubings, urine bags, vacuuminers, gloves were all included in the red category. Next was the white, which included waste sharps, which also includes the metallic sharps. And then there is a blue, which includes the grasswares. Here, the only glitch is that the ampules which are contaminated with cytotoxic waste will not be included in this blue color code. And also the metallic body implants were also a part of the blue waste. Next, it was made mandatory to pre-treat all the lab and microbiological waste as per the WHO guidelines or NACO guidelines. In addition to that, other items that had to be pre-treated were the discarded linen and mattresses. Please note here the disinfection method is a non-chlorinated chemical disinfection or sterilization or shredding. Next, the plan was to phase out the use of chlorinated plastic bags, gloves to reduce the emission of dioxin and furans. Also establishing the barcode system, which needless to say would help in the tracking of this waste. So next, it also made it mandatory to have a facility where we can store our color-coded, our biomedical waste, and it had to be a safe and ventilated location. This was obviously to ensure that there is no secondary handling of this waste or there's no scattering or spillage by the animals. Next was the training. This had to be reinforced, like the induction training and the continuous training that had to be done every year. And also immunization of all us healthcare workers who are involved in handling of waste against hepatitis B and tetanus. So these were the major changes that were seen in Schedule 1. So what about Schedule 2? This was majorly, Schedule 2 spoke about the standards for how to do the final disposal or the final treatment of waste, and what are the guidelines for the common biomedical waste treatment plant owner. So it emphasized that the owner of a common biomedical waste treatment plant should also take an active part in seeing that the biomedical waste is segregated and discarded properly. They also have to assist in the training programs. Existing incinerators shall achieve the standards of retention time, that is less than 2 seconds, and the dioxin and furan level to be monitored within 2 years from the date of this notification. So the standards for incinerator was that the residual time in the chambers will be less than 2 seconds. Standard for emission, the suspended particulate matter to be less than 50 nanogram per standard cubic meter. And also stack height should be a minimum of 30 meter above the ground. Plasma pyrolysis, again, the combustion efficiency should be at least 99.9%. Again, the stack height to be around 30 meter above the ground. And all the ash that is generated from this process to be disposed according to the hazardous waste management rules 2008. Now, there was also an additional standards for the liquid waste management. What they told here that all the healthcare facilities should have a effluent treatment plant. And this effluents from this plant should be tested every year. And this would be done by the State Pollution Control Board. Now, our effluents have to conform to the above standards. And in facilities, a smaller healthcare facility where we cannot have a ETP, effluent treatment plant, they can go for a liquid disinfection plan. There were two models that were proposed, that is a Hypotreat model or the Ludhiana model, and then there was this Karnataka model. So this looks complicated, but the bottom line here is that the effluent that is finally disposed of should have a residual chlorine of around more than 2 milligram per liter for safe disposal. So this was the bottom line in this liquid disinfection standards. And the state government or the union territory government will be providing the land for setting up the common biomedical waste treatment plant, and no occupier of a healthcare facility shall have an on-site treatment and disposal facility if the plant is available within 75 kilometers. And also there were some new rules for these owners of common biomedical waste treatment plant. That is the buffer zone was made mandatory in the biomedical waste rules 2016 if it is not located in the dedicated industrial area. The Schedule 3, which mainly includes the authorities and responsibilities for the various organizations. So we'll skip that and we'll come to Schedule 4. Schedule 4 speaks about the various labels, that is the biohazard label that we need to put up, the cytotoxic label that we need to put up, and also the label for transporting this biomedical waste bags or containers. These are the various forms. So there were 5 forms. One is the accident reporting form to have a better control and management of these, and also application for authorization. Now the authorization is made simpler. It's a one-time authorization for non-bedded healthcare facility and a synchronized authorization yearly for bedded healthcare facilities. And also annual reporting. This was a new thing that was added. That is the annual report of each healthcare facility. The amount of waste generated has to be submitted. And also application for filing the appeal. So this was a very comprehensive biomedical waste rules that was formulated. It includes everything from segregation to collection to transportation, everything. So what were the challenges in implementing these? First challenge, lack of funds. 2 years was a very short time span to phase out all the chlorinated plastic bags, blood bags, and also to establish a barcoding system. So this was a major challenge for most of the healthcare facility, and also the common biomedical waste treatment plant. In the year 2016, studies have shown that in India, there's only 198 treatment plant, out of which 28 was still under construction. So to fulfill the need of treatment, we need more of these plants. So these were the major challenges that all the healthcare facilities were facing. Next, there was an amendment in the year 2018. Major changes that were made was the time span to phase out this non-chlorinated, to phase out the chlorinated plastic bags, gloves and all was increased to March 27, 2019. And also the annual reporting was increased to further time was given till 2020. And the barcoding system, again, the time span was increased and it was time was given till March 27, 2019. Additional form, that is Form 4A, was formulated. Through this form, the State Pollution Control Board could compile, review and analyze the information and send it across to the Central Pollution Control Board. So these were the salient changes that were done in the amendment 2018. Of course, my talk would be incomplete if I don't touch upon the COVID-19 waste. So in the era of this pandemic, what is happening? How do we deal with this COVID-19 waste? Now we all know when we face a threat by an unknown agent, by an unknown biological agent, we need to take extra precautions. So that is what was done here. The cycle is very simple. The waste origin COVID what, the segregation is done as per the BMW rules 2016. It is all double bagged, labeled, disinfectant, chemical disinfection is done on the bags, and then it is transported to the common biomedical waste treatment plant, and from there high temperature treatment. So this is the details how it is done. Segregation and collection is as per BMW 2016 guidelines, double bagged and labeled as COVID waste. Separate registers to be maintained by each healthcare facility regarding the COVID waste that is generated in their respective facility. Also, transportation should be done in dedicated trolleys and trucks. Labeling of the vehicles is not recommended. And after such transportation, the vehicles to be cleaned with hypochlorite. Final disposal has to be taken up at a priority level, that is ideally within 24 hours, to report to State Pollution Control Board of the facilities which are sending these COVID waste, and maintain separate records for the COVID waste that is received. And quarantine camps, again, they need to have all these healthcare waste that they will be generating, that has to be separately collected in a biomedical waste bag, that is a yellow colored bag. So this was a basic gist of the COVID-19 waste handling. Again, there are many challenges with this as well. As you can see, this is the mountain of coronavirus related waste. So this was reported in one of the leading newspaper, and many more reports have been done on this, where we see the PP, that the huge quantum of waste that is increased because of COVID. In Korean study, it is shown that each patient generates around 10 kg of COVID waste. So you can just imagine that level, the level of waste that would be generated in India. So obviously we have a major challenge in tackling all this waste now. So what lies ahead? Is this the end of the story for us, or the story continues? Actually, it's not the end of the story, because we still have a lot to achieve. First, we need to look into whether the hospital can manage without these single-use plastic equipments, plastic devices that we're using, whether the manufacturers of these devices can move on and reduce the PVC level in these devices. We need to have a rethink of these things. And also whether we can have eco-sustainable PP, whether we can safely reuse this PP, reprocess and reuse this PP. This has to be thought upon. And next, how do we turn our medical waste into opportunity? Now, there are many new techniques that have been put up, like the gasification system. This is the auto gasification system. There's a pyrolysis method. And of course, there are non-incineration other methods that have been formulated. What happens in this is the amount of pollutants that is generated comes down. There is value-added products, the final end products that can be received and which can help the healthcare facility. And also it is more energy efficient. So with all this in mind, we really need to look in this direction. And with this slide and with a hope for a safer and greener tomorrow, I conclude my presentation. Thank you.
Thank you, Dr. Rupa, for your informative talk.
Thank you, ma'am.
Today's next speaker is Dr. Sanjeev Singh. Dr. Sanjeev Singh is a pediatrician by profession. He's pursued his master's in hospital management and completed his PhD in infection control. He is currently working as Chief Medical Superintendent at Amrita Institute of Medical Science and Research Center at Kochi. Dr. Sanjeev is also an ambassador from India to Society of Healthcare Epidemiology of America and has been adjudged as Heroes of Infection Control by Association of Professionals of Infection Control, United States. He is International Surveyor at International Society for Quality. He was member of Technical Committee at National Accreditation Board of Hospital, India, and was responsible in drafting accreditation standards for 3rd and 4th edition. Sir is presently the Vice Chairman at Research Committee at NABH. He is Chairman of Technical Committee at AHPI, that is Association of Healthcare Providers of India, and Health Sector Council of India, Government of India. He is a member of Drug Safety Council from Government of India and member of National Advisory Board on Occupational Exposures. He is also a member of Healthcare Committee at Federation of Indian Chamber of Commerce of India and Secretary of AHPI, Delhi. Today, sir is going to deliver a talk on formulating infection control program in your hospital based on NABH requirement. Over to you, sir.
Thank you very much, and namaskar to all of you. And thank you, JSS team, and especially Dr. Dayanand sir. I have been a great fan of yours, and I've been really following the work which you do in the various institutions where you have joined. And thank you, Dr. Divya and Dr. Mamta from the department for giving me this opportunity. I'll get started. I'll also like to thank all the panelists who have joined for today's fantastic session. Very well organized, and it's really a great opportunity to reconnect. So the topic which was given to me was infection prevention practices as per NABH 5th edition, and let's see whether we would be able to do justice. So whatever has been drafted, it is basically to prevent infection prevention, and that's the key. I'm not sure why we got George W. Bush here. I was looking for Donald Trump, and somehow I couldn't get that picture, but prevention is primary. Infection prevention is almost like a city traffic. It is extremely complex. It is however, wherever, whenever, and everybody has their own path. So there are many stakeholders, the resources are limited, there is weak governance because the leadership, they may not walk the talk, though they would understand it. We immediately jump for something which is easy, which is punitive culture. So if you realize somebody has a bloodstream infection and there is a breach in adherence, we would like to immediately punish rather than look for root cause. There is no focus as a patient safety as a comprehensive agenda. There are no infection preventionists and infectious disease experts. There are delayed investigation because somehow our surveillance is post facto and not real time. It is very lab-based. Infection prevention is lab-based. So basically you need to have a very comprehensive and tech-savvy lab where it could complement the clinical care. The key matrix is, as Dr. Dayanand ji had already covered, that those registries and the surveillance data analytics is not present. And the national policy, though it exists, the implementation is poor, and then there are only few states who have a dedicated policy for infection prevention. So there are global and national initiatives. It's not that nothing has been done. There are plenty of global opportunities from the guidelines which comes from CDC, WHO, International Health Regulation. And it's not that nothing has been done. Dr. Rupa had just mentioned, fantastic talk, Dr. Rupa. Biomedical waste management rules, there are Kayakalp program, there is clean hospital program, there is a national patient safety implementation framework. So it's not that nothing has been done. There is a lot of work which has already been done. So how do we put a structure in and process and outcome in place with respect to NABH 5th edition? So first is to put a good structure, it would be to have a good program. But what is written in the 5th standard is prevention and reducing the risk. So it's just not drafting an infection prevention program, but it is also about guidance note, which helps you to prevent and reduce the infection. So how does it help us? Where do we seek those guidances? So there is this multimodal strategy approach which WHO has brought in, which there are plenty of enablers. And then it talks about putting a program policies together, and it's a fantastic note. And similar thing has been adopted by the national guidelines by NCDC. Now, next is to identify a good high risk areas and the procedures which you do within the hospital. And I think thanks to COVID, fortunately, unfortunately, there's huge attention to infection prevention. And I think as an infection preventionist and as a healthcare administrators or healthcare worker, we should not lose this opportunity at all to drive down that infection prevention is key. Now, COVID-19, one of those high-risk procedures is aerosol generating. So do we need to make all changes everywhere with respect to structure, operation theater, ICU isolations? But the answer may be no, because we need to differentiate between aerosol and non-aerosol generating procedures, and it basically comes from an interim guidance from CDC. Now, how do you, can anybody help us to understand how do you put that structure in place? So WHO has an infection prevention assessment framework, which has 8 components, which talks about guidelines, education, training, surveillance, multimodal strategy, and workload. And there are 81 indicators which are important. Similar structure has been placed by CDC, which has 4 components, where it talks about facility demographics, it talks about infrastructure, it talks about direct observation, and it gives us the guidelines. So the guideline for laying down a good structure for infection prevention does exist. It also talks about engineering control, and that's again the key, because basically to avoid or to prevent healthcare associated infection at all levels, from operation theater to isolation rooms to procedure rooms, there are ISHRAE and ASHRAE guidelines, and a lot of it also comes for COVID as well. So how do we maintain those? But it is just not about indoor air quality, it is about water resources and water playing a major role in preventing of infection prevention. So NABH has come out with an operation theater guidelines, but what is also important is to understand that air conditioning is separate than air handling. So we generally would like to confuse, and there's a lot of talk which happened between during the COVID time. So it's basically monitoring of temperature, relative humidity, and fresh air changes is important. And air conditioning possibly would be fine, but provided we don't recirculate those air. And the guidance basically comes from CPWD guidelines and ISHRAE guidelines, which is dedicated for COVID. Now let's look at operation theater. There was this movement that all COVID-19 patients will have to be treated in negative pressure, and that's an overkill. It's good if you could do that, but then it is more of a process adherence rather than change in structure, which is going to be costly, which is also important. So there is a positive pressure operation theaters in almost all the facilities, and negative pressure dedicating it only for COVID-19 may not be a suitable idea, because in any case you'll have to prevent other healthcare associated infections like surgical site, bloodstream, ventilator associated pneumonia, and it should help us. So by creating, if we have created a negative pressure Pascal, 15 Pascal would be important for especially treating those COVID-19 patients. So how do we create a COVID-19 kind of a ward where, since I could not find anything, I drew myself. There is, you have a PP in an anti-room, you get to a cohorted, either a suspect or a positive patients, you maintain the distance, but what is key is having ventilation. So what is required is a 6 to 12 air changes, even during COVID positive patient. A good open window and a good open door gives you a 37 air changes, and that is where our age-old medical college facility with infectious diseases, which was open ventilation prone, was good. It has a dedicated loo. Then what is very, very key is the doffing area, which should have an exhaust, and you are able to doff properly. But post-doffing, there needs to be an adjacent shower area. And that is where structural changes became so difficult, but it is important to have that processes and having a dedicated equipments during this. So when we, so if the COVID-19 patient comes, so do we have to always admit in negative pressure room? The answer is no. you could cohort them and maintain them. But then there are requirement of, and I'm sure that this topic is going to be covered in detail, so I'll leave it like that. But there are requirements, of droplet infections and the contact isolations and airborne isolations, and this needs to be adhered so that we don't become a modem of transmission of infection across the hospital facility. Now, similarly, structure is required, changes would or modification would require in central supply sterile department, because there would be a soiled zone and there is a unidirectional flow between clean zone and packing zone, and a unidirectional flow between sterile area where you either steam or gas still do the gas sterilization and also store. So there is an entry and there is a separate exit where you issue the sterile equipments, and this basically comes from HSMS and WHO guidelines. What was new in infection control 5th edition guidelines is that they have also brought in that if there are constructions and if there are renovations, and that happens very much in almost all healthcare facility within the country, there needs to be infection control teams participation and monitoring. And this basically, as they are asking about architectural segregation, can we have a separate traffic flow and flow for materials, which should be basically planned. So there is a checklist which is basically infection control and risk assessment checklist, which has a risk stratification among this checklist, which needs to be also followed. And there are various classes, class 1 to class 4, which also gives us a good guidance for adherence during renovation and refurbishing. So what are the resources within the structure which would be required? And we know about from the COVID that there are lots of PPE, which is important, but then there it gets, according to the degree of difficulty, it gets different PPE should be adhered at different risk stratified zones. Now let's come to the process. Now, since 172 years, we have been talking about hand hygiene. So it basically got started with Oliver Holmes, and this is Ignace Semmelweis, who basically is now known as father of hand hygiene, who has been recommending it from almost more than a century, and we are still saying the same thing. And the adherence or the compliance is poor. A similar movement was taken by Florence Nightingale, Joseph Lister, and the guidelines also, the first guidelines for hand hygiene came in 1980. But what we follow is the WHO guidance on hand hygiene, which was released in 2009. And that, I think, is a good guidebook for us to adhere to. It talks about the steps which is required for hand hygiene, and it talks about the 5 moments. I'll also skip this because we would be covering this in the other talks. So in the 5th edition, there is a lot of importance which has been given to standard precautions plus transmission based, which leads to isolation precaution. And this would be covered in detail, but I would only like to strike a note for standard precautions, because we generally say standard precautions are barrier nursing and hand hygiene and PPE, but it is much more than that. So hand hygiene, PPE, and cough etiquette. Other than that, standard precaution also include sharp safety, injection practices, sterile instrument and device handling, and clean and disinfected environmental surfaces. So if we say that we would need to have a universal precaution or standard precaution, there's a lot of infection prevention activity which needs to be done. And there's huge movement which came up with the safe injection and infusion practices, just for example, and which is now driven by WHO guidance note, and NCDC in Government of India has also followed it. Now let's quickly come to the surveillance, which is the meat of infection prevention control program. So if you talk about surgical site safety infection, the importance and the the guidance which has been given with the 5th edition is more on prevention. So can we work on antimicrobial prophylaxis? Can we work on normothermia? Can we work on glucose control? Can we work on adequate oxygenation, alcohol-based skin antisepsis, and what is the right solution? And then for a dedicated clinical surgery protection program, and then there is surgical safety checklist. But then it also talks about hair removal and various recommendation and staff or your screening. So there is a compendium of guidelines which is available for prevention of surgical site infection, and that is what is the stress in the 5th edition. Now, if we talk about bloodstream infection, it has its own definition. The definition also would include from day of onset and the window period. So surveillance is key, and it all comes from CDC and HSN guidelines. But lab confirmed bloodstream infection, what we need to do and how do we need to prevent is the stress. So hand hygiene, hub cleaning, removal of central lines, ASAP, aseptic mechanism, subclavian being the preferred site is important. But we need to also adhere to some of those universal guidelines that we need to take, at least for good identification of bloodstream infection. We need to draw 2 samples, 2 separate and 2 different time zones. Urinary tract infection is becoming a big problem, and Dr. Dayanand did mention that the data is scarce. So there are 785 hospitals which are accredited, and we have some of the data which is being collected as a mandatory indicator by those hospitals which are accredited. So there is a national average, and then there is a state average, and that has been done almost every month, and it's submitted to NABH. So the urinary tract infection in India is becoming a big problem because one, the definitions and adherence to the definition is an issue, and the clinical adjustment with individualization is a problem. Plus, we are seeing an increased risk of multi-drug resistant organisms without presenting of signs and symptoms. So asymptomatic bacteriuria and their treatment is becoming a problem. Now, CDC did complicate ventilator-associated pneumonia, and they have trifurcated into VAE, IVAC, and possible ventilator-associated pneumonia. So this is a complicated algorithm, but somehow I think as a good team in the country, we also need to have some kind of a systematic review and revise if that is possible, because possibly the hospital-acquired pneumonia is much more important for us for so many facilities, 80,000 plus facility which is there in the country. So what do we need to do with ventilator-associated pneumonia is avoiding intubation, minimizing sedation, maintaining a good physical conditioning, minimize the pool of secretions, elevate the bed end, and maintain the ventilator circuit. So the importance is on the prevention and collection of the data. Disinfection and sterilization. So 5th edition has laid down again the importance of Spalding classification. So you use right kind of solutions at right kind of risk zones within the hospital. So the critical zones will have a high level disinfectant. So the practice, unfortunately, in the country is very faulty, and we think that Cidex 2% is the Ramban solution, and we somehow have a very borderline approach between high level disinfection and sterilization, and some critical interventional procedure. We don't adhere to some of the infection prevention practices, which is important. Now, coming to antimicrobial use and antibiotic stewardship program. So what NABH has added this time, so it was definitely there since 3rd and 4th edition, but there is a lot of importance which has been given to antibiotic stewardship. So what it basically is talking about, you identify a restricted antimicrobial agents within the hospital, and you can use the guidance of AWARE classification, which is a WHO classification. and it should be reviewed periodically, and look at some of those activity which is important for stewardship, monotherapy versus combination therapy, and can you de-escalate if your reports have come in, and don't continue for therapy for longer than what is required as per the recommendation. So generally we are in a habit of maintaining 5 days, 10 days, or 14 days. Now where does this 5-day, 10-day, 14-day comes from? It is a magical figure, but we don't know. But maximally 7 days of good antibiotic coverage is 7 to 8 days is good enough for most of the healthcare associated infections. Now ICMR also came out with an antibiotic policy and treatment guidelines. So it was more of a clinical guidelines where they have covered acute fever management, sepsis, and it is a fantastic resource material. So respiratory infections, skin, CNS, and all infections. So syndromic and disease-wise classification is done. So for antimicrobial stewardship, some of the strategies which have been recommended, and British Society for Antimicrobial Chemotherapy gives us some of the guidance notes. So there could be core strategies and supplemental strategies by formulating restrictions and pre-authorization and audit. But it is difficult. So the other strategy which has been adopted, which is been published by Chung at Virulence, is a front end and a back end strategy. But what in our setup, in the low middle income setup, starting smart and focus is a good strategy for antimicrobials. You allow people according to the antibiogram to start, because it's so difficult. ID physicians are not available 24/7, and the patients belongs to the clinicians, so they can start. But then we need to focus and review at day 1, day 3, day 7, and accordingly change the prescription practices. But antimicrobial stewardship alone will not work, and it needs to work in tandem with a good infection prevention practices, and that is the key. So it's a multimodal approach, and that is where we need to bring the behavioral change. It also, the 5th edition also talks about all support services. It talks about mortuary, housekeeping, laundry services across, and look at the effectiveness of the infection prevention at these areas. Vaccination, exposure prophylaxis is again one of those key. So hepatitis B plus appropriate vaccination in food and beverages area would also be important. Now, to sum up, there is data, and Dr. Dayanand did talk about that. So there is the healthcare associated CDC definition. We need to, for a good surveillance, we need to follow that and comply with that. There is a formula, and there is a continuity of collection of this data. So data for surveillance is the key. Now it will have no value if you don't have quality tools to analyze that data and make that impact. So there are some tools which are available. It is not that every time you use root cause analysis or PDCA. So there are various tools for various processes which needs to be used appropriately. But finally, what is important is also cost. And what we have realized is it is not, everything is not cost generating, but it is cost saving. So we have done this exercise at our facility. We invest close to 669 rupees in each training program, but what we save is close to 2 crore of rupees per department. So if I have 46 department, I save a lot. So my investment is 1 crore. My return of investment is 236 crore. And that is why prevention in hospital infection is important. So whatever we do, it has a cost implications, and we should be sort of put the practice of cost to good quality and cost to poor quality also in place. So infection prevention basically looks like a child's play, and it is not. And there's a lot of effort which needs to come in with respect to data, with respect to practices, and with respect to behavioral change. So that is it from my side, and hope we have a very, very safe days ahead. Thank you very much, and I would like to thank for the opportunity given by JSSN team and Dr. Dhyan. Thank you.
Thank Thank you, sir, for your descriptive talk on formulating infection control program in your hospital based on NABH. We request the panelists to look into the question and answers box as there are questions for panelists. The next speaker of the day is Dr. J. Jayalakshmi, Professor and Head of the Department of Microbiology, KMCH Institute of Health Science and Research, Coimbatore. Ma'am is an NABL NABH assessor. She is an internal surveyor for JCI. She is an editor for IAMM Tamil Nadu and Kaho newsletter. Ma'am is a program director for CPHIC, both basic and advanced. She is a certified professional for quality implementation in hospitals, both basic and advanced. Ma'am is a member for National Advisory Board, founder member of Infection Control Forum, and she is a BOS member of Devaraja Aras Medical College, Kolar. Ma'am has held the position of Medical Superintendent, PSG Hospital, and a Secretary, HIC, even the same PhD Hospital, and she's a conveyor for Antibiotic Committee, PhD Hospital. Our area of interest are infection prevention and control and molecular biology, quality assurance in medical professional education and healthcare facility. She has a membership at various professional bodies. Ma'am is going to talk on risk categorizations of areas and procedures in hospital. Over to you, ma'am. Ma'am, you have to unmute. Not it, ma'am.
Yeah, I'm so sorry. Thanks, Divya. Thank you so much for such a wonderful and a warm welcome. Thanks to the JSS management and as well as Colonel Dayanand sir and the entire team of JSS for giving me an opportunity to share my thought on a very important but in a very simple manner. And I would also like to thank all the panelists. So good to see all of them here on because at COVID times you don't meet them on site. This is good to meet all virtual. Good to see all of them. And a big salute to all the frontline healthcare professionals who are toiling day and night, working in COVID areas and the stress that they go through. And there is a huge risk for infection for themselves and for the others at home. But what we're going to talk today is a risk which is totally different, and that would be on categorization of the risks and of the areas and procedures in a hospital. So I'm going to just take you through the basics for people who are very new to the healthcare profession itself, healthcare system itself, just to take into the burden of the infection. See, healthcare associated are the most common adverse events during an healthcare delivery, leading to increased morbidity, mortality, increase in economic burden and quality of life. But if you look at what is these healthcare associated infection, anything that would occur in a patient who's been admitted for more than 48 hours in a hospital or any other healthcare facility, which was not present or incubating at the time of admission. So that would be earlier known as the nosocomial infection, now called as a healthcare associated infection. So on any given day, about 1 in 31 of the hospitalized patients have at least one healthcare associated infection. And the numbers could be up to 7% in developed countries, 10 to 30% in developed countries like India. And the good news is, of course, that healthcare associated infections are largely preventable and through very good and effective infection prevention control measures that we can institute. Now, this is a chain of infection for people who are new only, but however, it's good to look at them again. So you have these infectious agents and you have a reservoir on which they would stay. And there is a portal or a means of exit from these reservoirs to personals through a mode of transmission, which could be either a contact, which could be direct or indirect contact, or a droplet transmission or an airborne transmission, and goes into another person through a mean of or a portal of entry into another person or susceptible host who now succumbs to this infection, and this cycle would continue. And this is a chain, and you need to break them at different points if you want to prevent infection in any facility, in any system. So there are various ways. Either you identify them early, the infectious agent itself, so that you know how to handle them, or clean the reservoirs or remove the organisms from these reservoirs, protect them so that there is no means of exit from a person who's infected or from a source that is infected, prevent transmission by instituting proper infection control measures, prevent its entry into another person by way of various control measures and preventive measures or use of PPEs, protective measures, and increase the immune status of an individual, or prevent them with giving vaccinations so that the host is not susceptible to this infection. So these are different ways that you can break these infections. Now you look at the risk of infection in any hospital. Identifying and analyzing risks associated with healthcare infection is the most important and an integral part of any successful infection prevention control program itself. Now, in the context of infection control, risk is defined as the possibility of a microorganism either colonizing a person or infecting either a patient or a healthcare worker in the facility or the visitors who's coming into the hospital, which is arising from various activities within the healthcare facility. So these are the risks that we would want to see in the healthcare. It could be a low risk, somewhere midway between would be a moderate risk, or you could have a high risk. Now, this is the very simple risk analysis matrix, which need to be applied. In fact, all of us apply. COVID has made it more known to almost all categories of healthcare workers, and otherwise also we mentally make this matrix and to see what is the severity of this particular issue and how often is it going to occur. So severity and occurrence are the two components that you look at, and you see how often you would get them by a matrix. If you look at the severity or the consequences, which could be very insignificant, or it could be minor or moderate or a major or extreme or catastrophic. So it could be something like a death to nothing happening to somebody due to an infection. And how often is it occurring? So what is the likelihood of it is occurring, this particular activity occurring, or this particular instance occurring, this particular problem in the system occurring would be almost certain. Every time it is happening, or it is likely to happen, or it is possible to occur, unlikely, or very, very remote. Based on this, you have this matrix of 2 by 2, and you will have them scored based on almost certain and insignificant as 5, and you multiply like that to go to 1 to 5 would be coming under the category probably as low, and from 5 to 15 you categorize them in medium, and 16 and above takes it to the high level or high risk areas or zones that you would want to look at. So this matrix is very, very useful, and at all points we would be applying them. Now you look at this as a matrix, the same thing as you give them, you will now start to give them as per the scores. Now that you are able to see that they are either come under the low risk or medium risk or high risk, sometimes you can even put them into extreme risk depending on the scoring that you have. By doing this, what are we doing? We are able to prioritize them. We are able to list them into categories and say, which are these problems are serious for us to handle. Let me take you to an example where you're looking at drug-resistant organism. How often is this particular drug-resistant organism to be seen in the facility, and what is the seriousness that it can lead to, or what are the complications it can lead to? And based on that, it would lead to a score, and based on the scoring, you can prioritize to see whether it is a high priority or a medium or a moderate priority or a low priority that you need to work on and start to categorize. Now, in this, we have put them as the low risk, medium, and the high risk. This is in the low risk. We said you manage them on a routine by routine procedures, like you just institute some simple measures as a routine, reiterating a few processes and procedures and some practices so that they get corrected or rectified. And sometimes when you start working on your high risk activities, which are having the control measures or mitigation processes which are very much similar, or which has the same things that you would require for something that would lead to this low risk category. For example, instituting hand washing can bring about change across all infection control activities and parameters as well. But what you need to address for sure is the high risk areas. This is very serious and must be addressed immediately. And next would be, of course, the extremely risk one, which you don't want to have, because this is very catastrophic. You do not want them to occur at all. And that is important. Now, this is an infection control risk assessment matrix, as would be described in the JCI, where you have the potential risk problem, what I was mentioning. You can put any of them as your risk problem, as would be like even not vaccinating individuals. Okay, for hepatitis B. So how probable is it in your facility, and what is the serious impact it can have? And another component is added to this, which is what is the existing system or the current system or the preparedness. In the terms of diagnostics, you always look for the same risk assessment by adding what is called as detectability. Whether you're able to detect this issue or not, or are we prepared to handle this or not. So you never give the score as 0. It's usually from 1, because you need to multiply them. So you have 3 important components compared to what I gave you earlier, which is a 2 by 2. You're just adding one more component to it, just to see that whether there is an existing system, whether there is a preparedness to this. And then you give the score to it, and then you start to give the, you put them in the priority here. Now, based on the score here, okay, you will go give them. This is a different scoring pattern though. Okay, we could go with the same, less than 5, and then 5 to 15, and more than 15 also. Okay, so in the JCI, they have given it as 4, 5 to 10, and 10. So I have just taken as an example from them itself. So we could use any one of them and have this, and then you put them and you list which one is your top in the priority of its occurrence in the risk. Now, this looking at the risk matrix is not our key areas of today, but however, the same principle is what is going to apply into identifying our areas of risk within the hospital. Okay, let's take the COVID situation. Now, risk categorization in COVID situation, if you would see, this would be the low risk area where you have the non-patient care areas, okay, like the office, critical office areas or common places, etc. And the medical wards that house asymptomatic non-COVID-19 patients.
I mean, you have to share. I think you have to share. No?
Then you have this, they have no, or the healthcare workers can assume little to no exposure to COVID-19. So they come out of the low risk areas. Now you have those, when you start to screen them, then you have those in the moderate risk areas where you have the screening and triage clinics, where you have people with illness or symptoms of illness coming to those areas, or wards that house clinically stable patients with suspected or confirmed COVID-19. And those healthcare workers can assume or exposure to COVID-19 via droplet or fomites, where you don't see anything else. So they come under the moderate risk category. Then you have those high risks, which are those who are in the ICUs or procedure rooms that house seriously ill patients with suspected or confirmed COVID-19 patients, or healthcare workers can assume high risk exposures to aerosolized viral particles generated during these procedures, or severe cough, vomiting, and diarrhea. So when they have such symptoms, they would come under these high risk areas. So without our knowledge, we are doing a risk analysis and we are trying to see what is the severity and how often is it occurring, and see how prepared are we for this situation. And then we categorize them into 3 different or 4 different zones, depending on the situation and the practice of the place. This is how the risk categorization has been given in the NCDC National Guidelines document on infection prevention and control, where you would categorize them into the high risk areas, or those which have activities with the higher risk of infection getting transmitted to other persons by way of the procedures that are being done there, the type of activities that's happening here. If you would include in the high risk areas would be the operation theater units, okay, all the minor and the major, the ICUs, the pediatric, cardiac, neonatal ICUs, high dependency units, the emergency departments, the labor rooms, post-operative units, surgical wards, central sterile supplies department, radiation therapy units, chemotherapy units, dialysis unit, burns unit, isolation wards, all of these, and those restrooms within these areas also would come under these high risk areas. Now, the moderate risk areas are one which you need to identify based on how you work within the facility. It could change hospital to hospital and area to area, but however, most of them would be seen because sometimes the blood bank and the laboratory also would come under the high risk areas, depending on what type of activity is done in these laboratories and how often are these or what are the activities done in these blood banks as well. So this could be the laboratory areas, the blood banks, pharmacies, dietary, laundry, mortuary, and restrooms of routine restrooms, and the rehabilitation centers and psychiatric ward. All of these are moderate risk areas. When you look at the low risk areas, these are the ones which have the departmental areas, the office areas, the outpatient units, non-sterile supplies areas, and the library within the hospital or the organization, meeting rooms, and you have those post-operative units, which is later, and then the medical records or the medical record sections here in the stores section, the manifolds, the telephone rooms, etc. So all of these would come under the low risk areas based on those categorization that we looked at. Now, how does this help? This helps this risk categorization of these risk areas helps us in identifying what is the activity that is done, the clinical activity that is done, the exposure that may be there for people in all three categories, which is the patient, the healthcare worker, as well as the visitor in each of these areas. So this analysis would tell us what is actually happening there. And therefore, when you identify them as a high risk area, the type of practices that you would need to institute in them need to be much higher level. There is a load of organism which is higher. The people who are getting treated are more often. There is a higher levels of drug resistant organism in these setups. So therefore, you need to institute a better cleaning and disinfection practices. So therefore, the frequency is much more than that of the other areas. The level of cleaning also is slightly higher than the other areas. So the methodology of cleaning may be the same, but the frequency again would change by using the chemicals. The chemical that is used for disinfectants would change, and also evaluating or auditing these areas would also change, because you're going to audit these facilities much more frequently, so that you don't want anything to be missed in these areas. So that is the focus this high risk area would bring into. So if you look at this particular table, it says once in every 2 hours, and spot cleaning. Spot cleaning is cleaning those high touch points, because the transmission of infection is much from these high touch points than from any other surfaces that would be, which are frequently touched by all personnel within that healthcare facility. And the level of cleaning would be cleaning and with an intermediate level disinfection. And you have method of cleaning where you use soap and water, and then use disinfectant solution with concentration specified and periods specified, and you have either a fogging device or something to clean the entire surface, and high level cleaning would be required for all of these areas. Then in a moderate level, of course, the timing would get a little more spaced out, where you have once in 4 hours, or at least 4 times a day would be the frequent, and then cleaning with slightly lower levels of disinfectant than what you were using earlier, and then cleaning again with detergents, and then the disinfectants would be the same probably, but the concentration would vary. If you're using a 1% concentration in the high risk areas, it may be just requiring a 0.5 at these moderate risk areas. And the auditing or evaluating in these areas would also be slightly less frequent than the high risk areas. When you look at the low risk areas, these areas are the ones where you do a little often cleaning, And sometimes it's only the soap and water cleaning that is required, and sometimes a much diluted concentration of the disinfectants is used if it is only the office areas or common areas. And auditing may not be done as frequently as this, only to see whether these cleaning practices are being done in place. So it may be as far spaced as once in every 3 months. You look at the high risk procedures. Again, these are the procedures which have a high risk of transmission of or exposure to infectious material by way of various routes of transmission. It could be a contact, direct or indirect contact, or it could be by way of the mucous membrane, which could take these viruses or infectious material as effectively as a non-intact skin. And so you will have the organism getting in by way of procedures or some cuts and injuries. So these high risk procedures happening, and there could be transmission of these infections in from these procedures related. Now, what are these procedures that would require focus and attention? Would be those almost all the surgical procedures, the cardiac catheterizations, the endoscopic procedures, bone marrow transplantations, and any other transplantation surgeries or dialysis units, central venous line insertions, or tracheostomy procedures, or even ventilation, any aerosol generating procedures. Of course, this again would require a risk assessment being done and add more procedures into the facility depending on what is done. Sometimes the dental procedures may also would come into a high risk procedure in a facility, and depending on a situation, or where it is being done, which area is the procedure being done, again it becomes it takes up a higher priority of risk in transmitting infection. Therefore, you need to look at that when you identify these procedures in the list. Just to add on to what I think Dr. Sanjeev sir had already mentioned to you about the Spalding's classification, just want to take into the same aspect of it into how this Spalding's classification is made. It is based on the risk of infection which is associated with devices. Therefore, you classify, it has been classified into 3 categories of critical, semi-critical, and non-critical devices because of the risk that it may have in transmitting infection, because a critical device gets into the sterile parts of the body, and it comes into blood and body fluid contact, and therefore it requires sterilization, or at least a sterilant, which is a higher disinfectant which can kill the spores as well. In a semi-critical device is something that comes in contact with the mucous membrane or a non-intact skin, where you need to have a disinfectant which works effectively well. At the same time, it may not be as high as that sterilization process that would happen here. So usually the 2% glutaraldehyde or solutions which may be useful for these endoscope is a good example for a semi-critical device, which is and the disinfectant which is used for these semi-critical devices. And for a non-critical, where the device come in contact with the intact skin, so there is a cleaning with an intermediate level disinfectant, like which an alcohol or a phenol or chlorine based devices. The solutions can be used to clean up these devices which come in contact with the skin surfaces. So the ideal and the most often used one is the alcoholic based disinfectant solution. So based on the risk of infection which is associated with the devices, they get classified into how and what will be used. The other risk category that we can use for is based on the risk category of personnel involved. So you have the vaccination of them based on the category A, category B, and category C. The category A are those who have a high risk, where they have a direct contact with blood and body fluid, like doctors, nurses, surgeons, dentists within the workplace, who are coming in contact with patients, and they have a high risk of exposure to blood and body fluids. So those who are at the lower risk are in indirect contact with blood and body fluids, which may be by way of the fomites or the droplet which may be there on the surfaces. It may be a secretarial staff working in the ICU who stays within may not be handling the patients directly, but they are at a risk. So they are at a lower risk of infection than the doctors who come under the category A. So they come under the category B. Then you have those which category C, or the minimal risk one, are those like the dietary staff who walk in and out to just hand over the food, or the other support staff who may be there, who don't come in contact with patient or patient care areas at all. So those would be, or even the office staff who are with the organization or the hospital, they come under the minimal risk or the category C. So vaccination does not become universal to all. So you focus at high risk, or the category A would get maybe hepatitis A with influenza, which with the, depending on the areas of work, maybe additionally a chicken pox vaccination, or if they are going to be in the emergency area, maybe an additional rabies. All of these would be for a category A, but for a category B, there would be maybe hepatitis B, and for a category C, maybe it's hepatitis B, and if required, maybe if they are dietary staff, maybe a typhoid vaccine. So this is how the risk category of personnel are done for vaccination. This is just another way of categorizing based on the risk a person. So we looked at the risk for an area, risk for procedures, and risk for the devices and infection in the device through the devices, and then amongst the personnel. So now, what does these risks that we assess lead to? It can help us in focusing our infection prevention and control practices very strong into that focused areas. So any high risk areas, the surveillance activities get strengthened. All kind of surveillance activities on capturing the infections in these areas, or the processes that are going well and wrong in these areas, maybe a needle stick injury, hand washing procedures that have been done, or the use of disinfectant solutions, the concentration that they are being used, or the infections like the catheter-associated urinary tract infection, central line associated bloodstream infection, surgical site infection, ventilator-associated pneumonia, or the multi-drug resistant organism that are frequently isolated from these areas. So all of these surveillance activities are captured, and they are strengthened in all of these high-risk areas where you have most of these patients with infection in these areas. So the control for exposure to infectious organisms are done in these, or focused into these high-risk areas, where there is a hierarchy of control where you try to eliminate the hazard or the infectious material as far as possible, try to replace them, or you do have some engineering control so that you modify it, have some administrative control where you shift the person to another area of work, or which is of course the lowest of the in the hierarchy of control, which is most often used, is the use of PPE, which is the best way as of now to protect yourself from COVID infection from people. Wearing a good mask, which is universal masking, is one of the most important and the best way to prevent or the transmission of infection between people. The other would be to prevent all procedure-associated infection transmission by having care bundles in place. Care bundles are nothing but multiple individual activities of infection prevention put together collectively as a single bundle of care, and all of them done at all times. So this is a care bundle, and they are very specific for different infection or procedure associated infection transmission. It could be a care bundle specific for urinary categorization, or it could be for a central line, or it could be for ventilator, for surgicals. So you could have for the antibiotic use or a Clostridium difficile, you can have specific care bundles so that you prevent that infection specifically, or that procedure associated infection specifically, whereby you're using all preventive measures together as a complete bundle. The others would be to prevent any equipment related transmission of infection by having a very good disinfection and sterilization practice in place, having your devices, whatever device associated infections, which we spoke about, the ventilators, the central lines, or the catheters, and fluid or drug related infection transmissions, so that there is a safe transmission of drugs and body fluids. So you check into all of these parameters focused in all of these in these high risk areas, and getting all of them vaccinated specifically like what we saw, category A, B, C, and see which of these, which of the healthcare workers need to be vaccinated for what, depending on what they may be exposed to. Let's say if you get a COVID-19 vaccine available, then we will definitely have to make a risk strategy and a matrix and see which category of persons are those who will get the first line of these vaccines and then the others. So that should be our line of thinking and the way we would work. Of course, the most important and at all times the best would be to improving the hand hygiene compliance at all times. And this would again get strengthened in our risk areas or high risk areas, or whenever you're handling these procedures, which are high risk procedures itself. So our risk areas get the focused infection prevention control measures at all times. So the take home for today, which is quick to finish, is that categorizations are based on the risk of exposure to infection or infectious organisms. So you have them categorized into high, moderate, and low level of risks. So when you look at the high risk areas, they get the focus of attention. So this helps us to focus all our infection prevention activity from all areas into that area so that you can contain this infection as effectively as we can and as we plan to. Thank you very much. And any questions, I'll be very happy to take. And thank you, JSS, for giving me an opportunity to share my little thought with all of you on the risk areas and the risk procedures or high risk areas and procedures. Thank you.
Thank you, madam, for your enlightening talk on the risk categorization of areas and procedures in the hospital. We request the panelists to look into the question and answer box, as there are a few questions that are there for the panelists. We can again take it up in the panel discussion at the end. Our next speaker of the day is Dr. Vandana. Vandana madam is the professor and head, Department of Microbiology at Kasturba Medical College, Manipal. Madam has got the International Ambassador to the Society for Healthcare Epidemiology of America in 2016. Madam has also received the Fogarty Fellowship by the UAB AITRP to attend the Sparksman Center Summer Institute for Global Health at the UAB School of Public Health, USA in 2009. Madam has a lot of research grants. She is principal investigator in 3 international and 2 national, as well as co-investigator in 2 international as well as 8 national projects. She has 102 publications to her credit. She is guiding various PhD as well as MD candidates. Madam is also the endowment chair at Dr. TMA Pai Antimicrobial Stewardship by Manipal Academy of Higher Education and Research. Today, Madam will be talking on isolation precautions, contact, droplet, and airborne isolation. Over to you, Madam.
Thank you very much for this opportunity, and my special thanks to Colonel Dayananda. It's always a pleasure to be with Sir once again, and we just cherish our good memories of working with infection control with the great support of Sir when he was here. Thank you once again, Sir. Let me begin with the same famous chain of infection control and our efforts to break the chain of transmission. And we are here today. For the next couple of minutes, I'll be taking you through the transmission-based precautions to prevent transmission of certain infections in the healthcare associated system. And why that every building blocks are important, otherwise the motive of infection control will not be successful. We know the transmission of bugs within the healthcare system. There are patients, infected as well as uninfected patients, healthcare workers, and the environment. And the bugs and the infections, they transmit bidirectionally between these three. If you look at the complex scenario within the hospital system, we have the bugs which are found everywhere. Different bugs have a different transmission ability and their virulence factors. And there are many opportunities for the infection and the bugs to be transmitted due to complex healthcare management and the activities within the hospitals. And most important, hands are being used for every purpose in the healthcare activity, being a very common modality of transmitting the infection in the hospital. I would say the transmission-based precautions, something like running amok of an elephant. If it is let loose, the damage is unimaginable. It is just to restrain the bug and infection. It is not to catch hold of the patient and punish him, to make him feel as if it is a jail. It is not a bad experience at all, but as it is perceived in some moments. I request the audience to go through the story of a super spreader of SARS in 2003 in the Hotel Metropole of Hong Kong. So now let us come to the isolation precautions. They are nothing but creating barriers between the human's environment and the microbe. So the host may be an uninfected, susceptible patient or the healthcare personnel. The only motive of isolation precaution is to protect an uninfected host in the healthcare system. There are three important precautions: contact, droplet, and airborne precautions. They evolve in their level. Contact, little more is droplet, much more is airborne precaution. They are not mutually exclusive, they are inclusive of each other. The contact is included in the droplet, and droplet is always included in the contact, and the droplets are included in the airborne precautions. So nothing goes without the practice of standard precautions. The first and foremost is the practice of standard precaution, and these are the additional precautions carried out to protect the individual from certain infections. How do we decide what to follow and whom to implement, who will implement? Because there is always a big cost involved in practice of isolation precautions. But the safety and the cost has to be balanced. So before going to the implementation, any healthcare professional would ask a few questions. What is the microorganism we are concerned about? What is the source of the organism? Whether it is in the respiratory system or inside the blood or in the liver, whatever. And how it is spread. Is it airborne, contact, droplet, fecal-oral, or percutaneous? How it enters another host, and how long the agent is infectious. That means, when will I recall the isolation precaution? And what type of the procedures will the patient be undergoing, whether it is any surgical procedure or aerosol generating procedure? Is there any risk of, is there any evidence of person-to-person spread of the infection? Did the bacteria do the bacteria have significant antibiotic resistance? And how common is the problem in our hospital? Because the problems vary between hospital to hospital and nation to nation. And what is the risk of dispersal of this microorganism? For example, if we take the MRSA or the Staphylococcus aureus infection, the abscess is less dangerous than the oozing infection. So everybody should be asking these questions to themselves before going to implement the isolation precautions. There are certain factors. It is a collaborative effort of multidisciplinary individuals for a successful isolation precautions to be implemented in any system. First and foremost is the point of care risk assessment, early triage of different categories of these types of infection, early recognition and the source control and fast tracking of such individuals. But whatever we say, it is a coordination between all the healthcare individuals who practice standard precautions, and then the administrative controls and environmental and engineering controls. But if you go to the reality, this is what our most common OPDs in the public sector look like. And then this is slightly better, but not sufficient for any point of care risk assessment. Some private hospitals have gone to this level, but this also is not sufficient unless there is a proper risk assessment happening at the point of entry to the hospital. Most important is the point of care risk assessment within the hospital. Let us begin with the first contact precaution. So this is also called as barrier nursing. This applies to direct and indirect contact transmission. So what is direct? It is by direct touch between the infected and the uninfected. Indirect means through the fomite. These are the common organisms where contact precautions are followed. Methicillin-resistant Staphylococcus aureus, vancomycin-resistant enterococci, Clostridium difficile, norovirus and rotavirus diarrhea, and there is some significant, some doubtful application in case of MDR or XDR gram-negative bacilli, bacillary infections. Who needs to be isolated in terms of contact precaution? Patients with the known infection by these agents, patients who are colonized with these infectious agents, also asymptomatic patients who are suspected or under investigation for colonization or infection by these microorganisms. Infection is obvious, but colonization is subtle. So once the colonization is detected or suspected, one has to proceed for practice of contact precautions. What steps need to be followed in contact precaution? So this is the signboard which has to be available at every point of isolation. Visitors restriction is always the basic. They need to report to the nurse before entering into the patient area. First and foremost is practice of standard precaution and hand hygiene. Healthcare workers must concentrate on appropriate use of personal protective equipment such as gloves and gown in case of contact precautions. Masks are worn if there is any activity which spreads these microorganisms into the air. For example, bed making. A nurse who does the bed making in the morning need to be wearing mask because bed making creates a lot of airborne particles by these organisms into the air and they settle everywhere. Next important thing is the patient placement. How do we place the patients? Preference is always given to individual rooms, but it is not a very practical issue in India. So when you have more than one infected patients, they can be isolated together. But MRSA cannot be isolated along with the VRE. MRSA will be isolated only with the MRSA patient. If only one patient is there and the individual rooms are not available, this patient can be put with the other uninfected patients, maintaining a wide separation, especially in the corner of a large ward. But if the patient suffers from enteric infection and if the patient has active diarrhea, he always needs a separate bathroom facility for him. One important thing, never to share these patients with the compromised immune system or who undergo other invasive procedures. And environmental cleaning needs a dedicated items, should not be the mops and whatever the clothes should not be shared with the other areas of the hospital. Appropriate disinfectant to be followed. For example, for the cleaning of rooms of patient occupied by Clostridium difficile, simple benzalkonium chloride or quaternary ammonium compounds will not work, we need to use sodium hypochlorite for cleaning the room occupied by Clostridium difficile patient. And biomedical waste disposal should happen within the isolation facility, and those items used within the system should not be brought out to be mixed with the other biomedical waste of the other areas in the hospital. Next is the droplet precaution. This is done to prevent the transmission of pathogen spread through close respiratory or mucous membrane contact with the respiratory secretions, such as rubbing the eyes, etc. The pathogens that require droplet precaution do not remain infectious over long distance, more than 2 meters or 3 meters in a healthcare facility. So they do not require special air handling and ventilation to prevent droplet transmission. It doesn't mean that the patient can be made to occupy anywhere. Special air handling means it is just the heating, ventilation, and air conditioning, HVAC system. The organisms or the infections are influenza, meningococcal meningitis, pertussis, diphtheria, rubella, mumps, and coronavirus. They all they require droplet precautions. One need to understand the difference between the droplets and the droplet nuclei. Whenever an infected individual coughs, sneezes, sings, talks, vomits, large droplets are generated, which are more than 100 micrometer. The medium droplets, their size ranges from 5 to 100 micrometer, and small droplets, also called as droplet nuclei or aerosols, they measure less than 5 micrometer. So the larger ones are settled within 1 meter due to gravity, and the smaller ones, they take the airborne transmission and they go little far inside in the room. At the same time, the hands and the fomites in the environment may be contaminated. They also lead to direct contact or indirect contact to the susceptible individual. That is why the droplet precaution always starts with the contact precaution, and then some more additional precautions are carried out here. Again, visitor restriction is required, hand hygiene and standard precautions. Always the healthcare professional should wear personal protective equipment. Patient should be placed in the well-ventilated single room. If it is not available, cohort isolation of the same diseases. Door must always be closed. Bed distance should always be more than 1 meter. There should always be a sink and the bathroom available in the cohort facility, and a place for wearing and donning and doffing of personal protective equipment along with the hand sanitizer. And while working within 1 meter of the patient, a healthcare worker must wear 3-layer mask, face cover, glove, and gown, apron and eye cover if they are performing any activity leading to splash. When they do any aerosol generating procedures, always to wear N95 mask, face cover, gloves, gown, and apron. Additionally, appropriate environmental cleaning activities and biomedical waste disposal within the cohort system. It should be bagged within the isolation facility, not to be brought in, the item should not be brought outside without bagging inside the facility. Most important thing here I would like to highlight is the role of humidity while managing these type of infections that are transmitted through droplets. Humidity plays a very important role in their transmission. It affects the behavior of microbes within the droplets and the survival or inactivation of the virus on the surfaces. Dry indoor air facilitates the droplet to become airborne. If the relative humidity is less than 40%, the particles emitted by infected individual absorb less water, they remain lighter and fly farther. So the droplet becomes aerosolized and likely to aerosolize. And dry air also makes the mucous membranes in nose dry and more permeable to viruses. I'm bringing this point here because there is a misconception that air-conditioned rooms provide good humidity, etc. The air conditioning facility, especially the window ACs and the split ACs, they do not provide, rather they are deleterious to these type of infection transmission. They favor the infection transmission. Lastly, the airborne precautions. They prevent the transmission of infectious agent that remain infectious over long distance, such as measles, chickenpox, and TB. Here, the patient must be placed in the airborne infection isolation room, which is a single patient room equipped with special air handling and ventilation capacity, complying with the specific regulatory guidelines, such as CDC or ASHRAE or ISHRAE for India or American guidelines. Applies to TB, measles, and chickenpox. So here the most important is patient placement, appropriate PPE, and appropriate handling, again, for biomedical waste. A standard airborne infection isolation room is a luxury for Indian scenario for most of us. We do not have one in our hospital. The standard negative pressure airborne isolation appears like this. It has a negative pressure in comparison to the other sides of the hospital corridor, and which has a separate air handling units, which is not mixed with the other parts of the hospital. Single room patient with the ante-room and a private bathroom. Ante-room is again very important, where donning is done and hand hygiene is performed before entering the patient room. The door is always closed and the air is pumped into the room in a downward direction, goes like this. Patient's head end of the bed is towards the wall, where there is a HEPA filter and the suctioning, and the infected air goes like this. There is no recirculation of air. In the transverse image, it looks like this. The supply air goes like this, goes on to the patient and moves out of the exhaust, which is HEPA filtered preferably, and the exhaust air, which is situated at a 150 millimeter, that is 15 centimeter above the floor, to have a good exhaust. And the room should have minimum 12 air changes per hour. The design, the door is opening inside, not to the outside. There should be at least 1 inch distance below the door, between the door and the floor, to allow the air to pass inside, the outside air to pass inside. There is controlled ventilation, that is HVAC system. Negative pressure related to the other side of the hospital, that is 2.5 Pascal difference. Minimum 12, preferably 15. Air is exhausted directly to the outside from the ceiling, and in the separate the ducted tubes, it goes outside the building, which is away from the other buildings. There shouldn't be any adjacent building. If there is recirculation, not for tuberculosis, definitely, the air should pass through HEPA filtration system before return. One can install UV germicidal irradiation at the exit air. Door must always remain closed, and the staff must wear N95 or positive pressure ventilation system. There should be a dedicated bathroom. The air changes and removal efficacy, if we have 12 air changes, after 1 hour, 23 minutes, 99% of the infected particles will be removed. If there are low air changes, it takes a longer time for clearance of the infected particles from the room. So 15 gives a very good clearance. This is essential after any procedure, how later next healthcare worker or the next visit can happen. In a resource limited settings, we need not be so disheartened, because with the good consultation with the design and engineering group, one can make use of the natural ventilation in the best possible way to give a satisfactory isolation facility for resource limited settings. And also we can go for mixed ventilation, a combination of natural as well as some kind of an artificial ventilation, such as the exhaust fans. These are some of the images which are available in the WHO. This is a picture from Nepal, where they have constructed individual isolation rooms in the outside air, where there is a distance between the wall and the ceiling. And this is the whirlwind or whirly-bird exhaust fans, which drives away the air to through the top of the building. This is the whirlwind, which provides a very satisfactory exhaust facility. Otherwise, the old buildings which we used to see in the old hospitals, where the windows are situated like this and the wide corridors. This is another way of constructing airborne isolation facility for cohorting, where there are no adjacent buildings and there is a free flow of unidirectional flow of air. When somebody uses the natural ventilation optimally, with the open window and open door, both are kept 100% open, we really get 37 air changes per hour. But definitely this is influenced by the wind quality, closing of the door, the night time, the temperature, the direction of the air, etc. When the window is open and the door is closed, we get only 4.2 air changes per hour. This is what happens in most of the hospital, where the door is remain closed and only the windows are open. We do not get any good air changes. Only 4 air changes per hour we do get. And if the window is half open and the door is open, we get 28 air changes per hour. Just would like to share some of the points. There are some misconceptions about creating the airborne isolation or even the droplet precautions. The window or the split AC never provide negative pressure for airborne isolation, airborne infection prevention. They just provide some patient comfort by lowering the temperature. If one want to construct a proper negative pressure room, it should not have a false ceiling, because false ceiling leads to a lot of air leakages. Properly fitted exhaust fans help removal of aerosols only if the room has an inflow air. Without the inflow air, the exhaust fan just neutralizes the air transmission without removing the contaminated air. One good point to remember here is high roofing wards and ceiling fans. They help in the air dilution. Definitely, the infection is directly associated with the quantum of microbes they inhale. So any building with the high roofing and the ceiling fans really help in diluting the airborne infections. Not to undermine the use of PPE, especially in these negative pressure rooms, N95 mask, face cover, gown, apron, glove, which should be donned in the anteroom, and it should not be carried outside the negative pressure room. But it should be doffed once the healthcare worker comes out of the patient room. And double bagging is essential for any biomedical waste generated in the negative pressure. Finally, to sum up, for successful implementation, one need to develop checklist appropriate for those areas. Compliance monitoring is very essential. Regular maintenance of these the air conditioning or HVAC system is most important, because one study in Hong Kong showed that after installation of negative pressure rooms, after 1 year, 50% of them were not working. Audit and feedback is very essential for the sustenance of these negative pressure, these contact precaution, the isolation precautions to be followed continuously and for a sustainable. This is all I have. Thank you very much for.
Thank you so much for your informative talk on isolation precautions. Moving on to the next session, we have Dr. Chiranjay Mahopadhyay, who is going to talk about hand hygiene and monitoring. Does it have any impact on AMR? Before we get into the session, let us have a brief introduction about the speaker.
Let me see.
Dr. Chiranjay Mukhopadhyay is the Associate Dean and Professor of Microbiology, Director, Manipal Institute of Virology, MAHE. He is clinical microbiologist, clinician, scientist, and infectious disease specialist researching tropical bacterial infections with a special interest in melioidosis and global infection, including antimicrobial resistance and diagnostic stewardship. Sir was selected for prestigious Leadership in Academician program by IISER Kolkata and Leadership for Improving Higher Education in India by Harvard Graduate School of Education, Harvard University, Cambridge, USA under Ministry of Human Resource Development, Government of India in February to March 2019. Sir, to his credit, has total 56 grants from the year 2007 to 2019 and has completed 35 of them. Sir is the principal investigator in 26 national and international projects. To his credit, Sir has 150 plus publications with 1,834 citations with H index of 24. Sir, we welcome you to the session. Over to you, sir.
The video. Good morning. I hope I'm audible. Thanks to department. You can hear me?
Yes, sir, we can hear you.
Thank you very much. Thanks to Department of Health System Management Studies, JSS Academic of Higher Education and Research. And thanks to our very beloved Dr. Colonel M. Dayananda sir. We are very much indebted to him for what we have achieved today. Hand hygiene and monitoring. This is a very favorite topic for me, and more favorite, I have added that AMR, how does it have an impact on AMR? I know that in this COVID era, we have forgotten, we have another problem called AMR. And I can tell you that AMR was there, AMR is still there, and we may have COVID vaccine in the future, but we may definitely not having any vaccine against AMR, antimicrobial resistance in future. So very briefly, I will finish. I have planned it, that what is the present AMR situation in India? How should we follow hand hygiene and monitoring in hospitals? Does hand hygiene reduce COVID-19? And does it have any effect on AMR? So these are the few key questions which I will try to answer. The first is, what is the present AMR situation in India? And I will come to this. It may look a little crowded, but if you start from the left corner down, you see that 1980s was the happy period where most of the patients were treated with third generation cephalosporin because that was the drug of choice. Over the years, we have developed resistance to third generation cephalosporin. We have had MRSA. We had vancomycin resistance enterococci. To combat the third generation cephalosporin resistance, we had BL-BLI combinations in our hospitals from 1990s onwards. And then in the mid 90s, we have introduced with carbapenem. Unfortunately, from this millennium onwards, we developed carbapenem resistance, vancomycin resistance, linezolide resistance in enterococci and in staphylococcus. In 2010, we are started facing the era. Actually, we have started thinking, are we facing a post-antibiotic era? Because our BLBLA resistance has reached to 90%, carbapenem 50 to 60%, MRSA and VRD is rising. Colistin was introduced, tigecycline, minocycline was introduced in that period, and many more new drugs like ceftazidime, avibactam. But unfortunately, at the present moment where we are standing, we don't have much choices. And still we believe that antibiotics can cure. But here actually comes the role of hand hygiene. If we can follow hand hygiene and if we can monitor them well, we can get rid not only of corona or other viral infections, not only of other infections, as Dr. Vandana was mentioning, about the chain of infection from transmission to portal of entry, how we break the chain. One process is hand hygiene. If we go back and if we see that World Hand Hygiene Day, 5th May 2017, it has been told, the slogan was, fight antibiotic resistance, it's in your hands. So we understand that antibiotic resistance is directly connected with hand hygiene. 1 out of every 10 patients gets an infection while receiving care. And up to 32% patients receiving surgical care get a post-operative infection, of which up to 51% are resistant to treatment. So the situation is gloomy. We are having a lot of infections in the hospitals. Most of the infections are antimicrobial resistance. We don't have choice, but do we follow hand hygiene? I will give a glimpse. This is the left-hand side picture. This is the picture of a culture plate where the growth of Klebsiella, the microbiologist, we call it heavy growth because we call it more than 10 to the power 5 colony forming unit growth on the plate. We can visualize the growth, but do you believe that we carry the same growth in our hand? Total count of bacteria on the hands of medical staff, they range from 10 to the power 4 to 10 to the power 6. We can't see. What we can't see, we don't believe. But understand that we have similar number of bacteria in our hands. And the number is increasing with the duration of the activities. A nurse can contaminate their hands with 100 to 1,000 colony forming unit of Klebsiella, even when they are doing a clean activity. So now the question comes, does that particular nurse can transmit infection? So I am putting a table for you down where you can see that Klebsiella aerogenes caused urinary tract infections in 17 nosocomial infections in 17 patients where nurse was the carrier. So now see the direct implication of the skin flora in a hospital which is probably multi-drug resistant and full of growth of bacteria, and that can cause infection to the patients if we don't do. And what are these types of infections? It may be Staphylococcus aureus, which causing soft skin and soft tissue infections, E. coli, which is probably ESBL and which is causing urinary tract infection, Klebsiella, which is probably carba resistant, or Acinetobacter, which is colistin resistant nowadays, causing lower respiratory infections. These we are encountering every day in our hospitals. The colonization rates with Staphylococcus aureus was higher among doctors than nurses. So the onus lies with not only with the nurses, but with the doctors, maybe more, to wash their hands. As was the bacterial density of Staphylococcus aureus on the hands was 21%, more in case of doctors than the nurses. And colonization rates of gram-negative bacteria on the hands of health workers ranging from 21 to 86%, being highest in the ICUs. So what we are talking is not theory. This is practical, and this is actually happening. Now, what are the hand sanitizers we are using in the hospitals? Most of the hospitals were using alcohol hand sanitizers. That's good, because alcohol can act on gram-positive, gram-negative, virus-enveloped, virus non-enveloped, even mycobacteria and fungi. So, and sometimes in our hospital, we add with chlorhexidines with alcohols, and they have a very good actions. If you see, they can be used as hand rubs as well as hand wash. And the concentration is typical. We should maintain the concentration. And I should also tell you that whenever in your hospital you have hand rubs or hand sanitizers, see the manufacturing date and the expiry date, because many of us do not believe that it can have an expiry date, but it has an expiry date. It has a very fast and immediate actions. Alcohol hand sanitizer actually alters the structure of proteins. They destroy the cell wall and membranes of the bacterial cells and the envelopes of the viruses. So they are very good against the enveloped viruses like coronavirus. Alcohol hand rub is very good for them. But understand one thing, that if your hand is dirty and soiled, it may not work. So you have to clean your hand with soap and water. You have to get it dried. Then you have to use hand sanitizer, which we don't know many times, or we ignore. So minimum of 60% alcohol and wash for 20 seconds is needed. This is the WHO guideline for hand hygiene for healthcare. I am not going in details, but you understand that the components of WHO multimodal hand hygiene improvement facilities, they have a system in place. They want training, they want evaluation and feedback, they want reminder in the workplace, and institutional safety climate. Along with that 5 movements. We keep on talking about 5 moments of hand hygiene. But actually, in truly speaking, many of us, if we see mainly, we do not follow many of these 1, 2, 3, 4, 5. We ignore the 5 most often. Sometimes we are following, we forget to follow that number 2. So these are few steps we don't. So in that case, 5 moments of hand hygiene in healthcare, we must have to follow if we want to implement a good hand hygiene practice. So facility preparedness should be there. Baseline evaluation should be there. Implementation should be there. There should be follow-up and review. So today I am going to talk about in our hospital how we process the process of monitoring, practices in our hospital setup, what we practice here, what is how we have created the awareness in our hospitals, and what are the trends of hand hygiene over years. Process of monitoring. Actually, if you understand the direct method, there are many methods of process of monitoring. One is direct method. Observer will stand, the observer is validated, and he or she will stand and he or she will observe. That is the direct method, reliable, but large effort is needed. You should have a very good trained, validated manpower in place. Self-reporting, second. Inexpensive, but not reliable. Any healthcare worker, if you ask, they will definitely tell you, yes, I have washed my hand. Do you believe that? Because if you see and if you write to recon form, you will be disappointed. Direct observation by the patients. Patients will tell you. Inexpensive again, but potentially it may not be reliable again, and there will be a negative impact potential between the patient and doctors or nurses. If patients started telling that I have seen my doctor not washing hands, do you think that next how the patient will be treated by the doctors in our setting? Indirect observations. Some places we do that. Consumptions of the hygiene products, how many alcohol-based hand rubs being used in this hospital? Yes, it is reliable, it is inexpensive. You can number of bottles, you can find out you can calculate this month, this many alcohol hand rubs being used, this much soap has been used, but it is not reliable again, because you don't know that using the alcohol hand rub and maintaining all the process, the whole process of hand hygiene is done or not. Automated, less observation bias, but we don't have much data about that. This is one interesting part which I'm coming, and I will take little time for this. This is the way in our hospital we have set up the observer. We call it infection control nurses. They are the observers. So their profile and task of the observers we have to define, because they have to observe the healthcare workers during the usual care activity and to assess their compliance. So the observer has to be able, they have to be able to understand the logic of care. They cannot do it very from the spinal level in a very mechanical way. They have to understand the logic. Most important is the training of the observer. It is, you cannot just appoint, a nurse cannot just be appointed as an observer or infection control nurse, because it needs some training and very rigorous training. And that trained person should know the principles of 5 movements of hand hygiene. And that training should be confirmed through observation by a senior observer. In our case, hospital infection control committee chairman or the nursing superintendent should do this. Then we validate the observer. We validate by observing them jointly with the confirmed observer, but there is another method which the WHO implementation toolkit, which we use sometimes to validate the observers. Fifth is understanding the observation form. We found once upon a time that our infection control nurses, they find it very difficult to understand the observation form. The observation form is uniquely prepared for your hospital. And that observation form is, the material is ergonomic for observation. There can be used a pencil, morning, they stand, and they can do, it has a header and columns, all those are there. It will be determining the scope of an observation period. This is the observation is the distinction between indications and opportunities. Indication is the reason why hand hygiene is necessary at a given moment. And opportunity is much more relevant to the observer. It determines the need to perform the hand hygiene action, whether the reason is single or multiple. Because opportunity constitutes the denominator for calculating compliance. Then you can, our system, they should, in our hospital infection control nurses, they should select the location and time. How do you know? You know which time your ICU is getting crowded. In our system, we have found that from 8 to 11, it gets highly crowded, unexplainably crowded, and without any single reason. Because everyone wants to see their patient and finish it off. So that is the time you have the infection control nurses should understand and stand and find out, and they have to select the healthcare workers, which department, which particular segment they are going to observe. It can have a selection bias sometimes, which we have to look into. Therefore, we tell them to choose randomly. And then when they do that, one important problem you will face, the moment the infection control nurses will stand and they will start observing, you will find there is an awareness created, and that is a false awareness. People will start washing their hands. And what the data you get, actually that may not be the actual data. So that their presence may influence the result. So that has to be taken care. We prefer our hospital infection control nurses should not have a separate dress code, but unfortunately now they're having a separate dress code, and their presence are felt.
More
Analysis and reporting of the results is important.
Because right now webinar time patient.
And ultimately there should be a feedback. Your feedback should not irritate the hospital healthcare workers.
3 o'clock
it should not irritate the it should be it is a very powerful promotional tool.
1:30
It is a very powerful promotional tool, but it should be used very carefully. In our process, we do daily monitoring among the doctors and nurses. If there is a wrong actions or non-compliance, we immediately give the feedback to concerned defaulters. And we make them aware and train them at the personal level. After correcting their actions and practice, we take weekly meeting with the core members of the hospital infection control. Then we have monthly data analysis, and then we have quarterly meeting with hospital infection control members along with administration. So one thing I will insist, you have to have your administration with you. Without administration, you cannot practice hospital infection control practices, infection prevention control, hand hygiene in your hospital. And your feedback is very important to the concerned unit, but it should be polite, it should be humble, as well as it should be very effective. So how we process every day. We process randomly. Each unit who is entering the ICUs and hospitals, we take care of them. 30 minutes we do, maximum 3 opportunities we observe, and total compliance is calculated. We use the WHO hand hygiene observation toolkit, and during rounds and during any procedure, maybe any procedure, aseptic procedure, blood and body fluid exposure, after the patient contact, after the environmental contact, we take care that it is followed or not. This is the process of monitoring we follow here. And here, how we create awareness. So again, I want to express our gratefulness to Dr. Colonel M. Dayananda sir. He led from the forefront the whole infection control team, and that time I was the chairman, and I was very much indebted and grateful for his support. And with his support and with his leadership, we raised the bar in October 15, 2016. And we have hand sanitization relay, where we got the Guinness Book of World Records, where we got 3,422 people in one day. We had, and it is still not broken. So we need leadership, and we need the administration by your side. Otherwise, you cannot achieve the goal. We keep on creating awareness. This is, it may look like that it is not a very fulfilling achievement, but yes, actually it is. We do poster competitions, hand hygiene practices, teaching to patients by standards. So those people who are coming to the hospital to see their patients, they also contribute and they should follow the hand hygiene. We do role play, we do mime, and we involve the administrations here. You can see the administrator here. You see the mime. You can see the small boy who is showing us how to do the hand hygiene practices. And there are the posters. 2018, 2019, when Dr. Vandana was the chairman, again we followed that. We had a booth where people came, people understood, people observed how it has been displayed, how it should be done. Here patients came, patient bystanders came, and we had clean care for all. It's in your hands. That was the slogan that year. 2020, during the Corona period, we still had, now at present, Dr. Muralidhar Verma is the chairman, but still under this same tradition is being continued. We had lectures, we had posters. But the part is the compliance rate. If I show you the compliance rate, you see the compliance rate of the nurses in orange and doctors in blue. And you see that when we expect the highest patient load, June, July, August, it comes down. And this is the challenge. 2018, same we are getting in 2019, little improvement, but what we say, it cannot be 62%, it cannot be 90%, it cannot even be 99%. It is either 100% or zero, because 99% is not achieving the goal. So we take a lot of innovative methods to create the awareness, and we can see that this year, unfortunately, when everywhere is preaching about hand hygiene and everywhere it is there, and that is one of the main thing to fight against Corona, it has come down. So hand hygiene compliance over the years, it was satisfactory to some extent. The effort has been taken, but we are not very happy. We should have it more. Does hand wash save from COVID? You know everything about COVID now. Everywhere in WhatsApp, in every messages, mails, everywhere it is available. So I'm not going in details, but we should know that human touches their face almost 17 to 23 times per hour. Many of you are now listening and you are touching your face. Out of them, 42 to 44% are the proximity in the mucous membrane. And out of them, 36% is mouth, 31% nose. So enveloped viruses like corona and influenza viruses, they may find facial region favorable because it is warmer, it is more humid next to hand. And viral particle, which is very close to the nose, during the periodical exhale and inhale with the convective flows, you can see that highest face surface area. This is the area where this is the highest periodic inhale, exhale, convective flows are there. And through that, if there is any viral contamination, it immediately goes inside. And from where it comes through your hand. So yes, hand hygiene, WHO says that clean your hands in the context of COVID-19, but using proper techniques. We always have a false illusions that hand hygiene can prevent COVID transmission. It is not that. Everything, masks should be in place. You should know how to wear the mask. Hand hygiene should be there. You should maintain the social distancing. Everything in place. Then only we will be able to prevent COVID-19. Challenge is whether hand hygiene facilities is available and accessible to all. And ultimately, I'm coming back to AMR from where I have started. And you understand that AMR is an iceberg. And the tip of the iceberg, in the epicenter, we had the hand. Whose hand it is? This hand is of the healthcare workers, doctors and nurses. They are either collecting the infection from the environment, food, or the patients, and they're transporting to other patients or the environment. So once hand hygiene is done, it can prevent not only COVID, not only other viral infections, it can prevent AMR, which we'll never have a vaccine for. So I will finish with the Semmelweis, who started it and who was appointed as a house officer in the obstetric clinics. And he understood that there is puerperal fever, and in that hospital, he could not find the solutions. So he understood that the cadaverous particles was transmitted by the hands of the doctors and students from the autopsy room to the delivery theaters and caused puerperal fever. And he recommended that hands to be scrubbed in the chlorinated lime solutions before every patient contact. And it is which year? 1847. And after so many years after, our hand hygiene compliance is very poor. And that is the unfortunate part. Hope in future we will be able to achieve 100% hand compliance. Otherwise, we will go to the pre-Semmelweis era and we will have every infection with no cure. Thank you very much. And you can mail me or I can participate in the panel discussion. Thank you very much.
Thank you, sir, for your informative session on hand hygiene and monitoring. Moving on to the next session on infection prevention and control in COVID-19, practical issues in hospital by Dr. M.D. Ravi, sir. A brief introduction about sir. Dr. M.D. Ravi is the professor of pediatrics and chairman of Hospital Infection Control Committee of JSS Hospital, Mysuru. He has teaching experience of 25 years of undergraduate students and 16 years of postgraduate, as well as experience as a PhD guide. With this experience, he has held a number of additional positions. To name a few, he was the chairman of Scientific Committee of State Pedicon in 2008, member of Academic Council, Rajiv Gandhi University from 2008 to 9, member of Academic Council of Sri Devaraja's Medical College, Kolar, member expert group of Global Vaccine Safety Initiative, and in charge of AEFI monitoring cell of WHO at JSS Medical College. Sir has undergone number of training, to name a few, like developmental assessment at CMC Vellore in 1998, pediatric nutrition at Chennai in 2009, DSMB Harvard University USA in 2013, GMP and GCP training multiple times, and vaccine safety basics by WHO in 2020. Sir has 4 ongoing projects to his credits and has completed 17 projects till now. He is also a member of several professional bodies. Sir, we welcome you to the session once again. Over to you, sir.
Thank you very much, and thanks to the institution for having me on this panel. It's quite intimidating considering that I'm the only clinician here with no administrative backing and background, and not being a microbiologist. I'm chairman of HICC more by default than by knowledge. So I'll try to do the best that I can, and please forgive me if there are any lapses. So what I'm going to try to talk about is practically what we had, the problem that we had in our hospital, and on the basis of that, maybe you can get a few insights as to what you could do in your own place. So it's more of the practical issues that we had in the hospital rather than talking about theory about what should be done. This is actually what was done. Now, as far as hospital is concerned, COVID-19 created quite an unprecedented situation. We had a functioning HICC for a long time. We had multiple protocols in place. Everything was going live well until suddenly the COVID-19 pandemic came in and everything was thrown out of gear. We had to reinvent the entire system of protocols and so forth. The problem was that at least in the initial stages, we knew nothing much about the disease. Well into the several months after the disease has become a pandemic and everybody knows about COVID-19, we still don't know very much about the disease. So the disease itself was evolving. The responses to the pandemic were also evolved concurrently. So there were changes that were happening on an almost daily basis. Protocols changed, procedures changed, and our challenges also changed at the same time. So for this talk, I decided to divide it into two phases because they were quite different. The first was the initial phase, and then there was the middle part, which was like homeostasis. You know, we achieved some kind of stability and it went on for some time. And then we are now into what I call the current phase, which has changed us again. So in the initial phases, the first thing that happened was a major kind of panic. Everybody said, COVID, if you get COVID, you're going to die. So there were issues as far as handling a patient was concerned. Anybody who walked into the hospital who had a fever or a cough or a running nose was a possible COVID. So the question arose, what do we do with these people when we don't know whether they are COVID or not COVID? So a flu clinic was started in a separate part of the hospital with a separate entrance and exit. And this flu clinic initially was manned by the medical staff and the pediatric staff. We had two flu clinics, medical and pediatric. And then what happened was that everybody with a cough, cold, and fever was shunted into the flu clinic, as a result of which the flu clinic became like a market with almost all the patients crowding over there, and the OPDs became empty because apart from chronic patients, especially in pediatrics, I'm a pediatrician, so especially in pediatrics, it became almost empty. So at the same time, a lot of health facilities closed down. Private health facilities, a large number of closed down. Some hospitals were converted into COVID hospitals and people were not prepared to go there. So this resulted in a lot of congestion in the flu clinic. And what we did therefore was we revamped the flu clinic. Staffing was increased. Now, in the initial stages, the number of PPEs and masks that were being made in the country was small. So we had a problem with accessing enough PPEs and masks for the COVID wards and for the people who are working with various COVID patients. Courtesy of the sustained efforts of the director and some of our staff members, the nephrologists and so forth, we were able to get over the situation by accessing enough PPEs and masks. But in the initial phases, it was kind of a touch and go situation. Then we had a major problem of morale. I think the director mentioned it in the introduction itself, that even the medical fraternity got scared of COVID-19. So we had morale problems in all levels, but the major problem that we had was in housekeeping, because they were handling the COVID waste and they were handling the sanitizing the areas where the COVID patients were. And obviously, since they were not highly educated people, the scare factor, the fear factor was much more with them. This required multiple counseling sessions to sanitize the flu clinic and so forth. I'll come back to this a little later. So we started with multiple areas where we started working. First thing that we required was a training team. So a core training team was created from the HICC group, which included our HICC trained staff nurses. And this group, this training team was headed by our HICC coordinator, who is incidentally also a pediatrician. He's a pediatric intensivist, Dr. Chetak. So he headed this team. And training programs were done by this team for all the staff, medical, paramedical, support staff, office staff, the lift operators, everybody was trained as to COVID-specific measures that needed to be taken, both for self-protection and for prevention of infection. And the training sessions had to keep on getting repeated because there is a certain amount of attrition, there's a certain amount of turnover, new people join, and all these new people were trained in batches, whether it was nurses, whether it was fresh interns and so forth. So the training sessions were not just a one-off session, it had to it kept on going on. Now, I should really appreciate my HICC staff, because not only were they involved in the supervision of whatever the infection control procedures were going on, but they also had to take time off to train these people. So it was a kind of a double burden for them. The first problem that we had with the housekeeping was the morale, as I said. The housekeeping staff was absolutely petrified as far as going into areas where COVID was possible. Flu clinic, for example, where a good amount of waste was being generated. We needed to sanitize the tables, chairs, everything after each session. So all that required a lot of housekeeping staff. So we had a morale problem there. We had to have additional sessions for them to demystify COVID and tell them that, you know, exactly what COVID-19 was and how we could help, how we could prevent ourselves from getting it. So retraining for the COVID specific sanitizing measures also had to be done. We had protocols already in place for spills, for everything else as per NABH standards, but there were specific sanitizing measures for the surface sanitization, for example, for the tables and the chairs where the flu clinic was being done, for the PPE areas, the donning and doffing areas. All this had to be, we had to retrain these people on the new measures that needed to be implemented. And all this was supervised by the HICC staff, the staff nurses, who I had to unfortunately put them on a rota basis and say, you take care of this floor and you take care of that and so forth. So they were literally chasing their own tails. They were running behind all these various areas, supervising and training at the same time. We had also to create an inpatient facility. So we had to identify a ward which is accessible directly from the flu area. We created something like the, the green corridor we create to get a transplant organ from here to there. We created a virtual corridor inside the hospital from the flu clinic to the admission ward. And this included a dedicated lift, so that whole area was kind of sealed off from the general movement area. And the patients were able to be shifted from the outpatient clinic to a ward which is next door, and then subsequently to another ward which is on the first floor, on the second floor through a dedicated lift. This ward was managed by medical staff, the medicine department staff on a rota basis, generally with 6-hour shift. And these people were segregated from the other ward. They were restricted to the COVID ward. We had a problem because we had investigations that needed to be done. And obviously, you can't shift a 300 MA X-ray unit into the COVID ward. So we had to create timings when we could shift them. Or if it was an emergency, again, a corridor, virtual corridor was created between the ward and the various departments where the X-ray or whatever needed to be done. So this had to be done without exposure of these patients or the staff who are in PPE to other patients as well. Now, ours is a hospital which has a primarily rural population, and visiting people at the hospital is kind of a done thing here. It's like an outing. So number of visitors in a routine day was very, very large. And suddenly COVID came in before it kind of sunk in, and before the transportation problem started, the number of visitors was quite large. So we had to make restrictions. OPD patients were given only one attender, unless there are always exceptions to the rule, but as a rule, it was one patient with one attender. COVID areas, we did not have any attenders at all. Any communication with the patients and attenders was done by video conferencing, so that the COVID area was completely segregated. Oh, people died. Yes, people with COVID also died. And we had to take special measures to take care of dead bodies. There's a whole protocol for COVID bodies to be taken care of. Fortunately, our district administration was extremely helpful with us. I must really say hats off to them. They cooperated so beautifully. They would come as soon as we called and take care of all the precautions. But we also had to have some precautions in place till the bodies were collected, which means that the mortuary staff needed to be trained how to handle these bodies, what is to be done after the body is removed, how to sanitize post-removal of the body, and so forth. Communication was established between our health authorities, the coordinator for COVID, and the health authorities as to rapid removal of dead bodies. And this went off extremely well. We didn't have any hiccups in this process. Now, in the initial stages at least, protocols by the Ministry of Health, by various organizations, were being changed almost on a daily basis. Every morning, before I came to the hospital, I had to check to see whether there were any protocol changes. The director was very helpful. We had meetings with the top brass on a daily basis. We used to discuss what were the changes in the protocols which happened overnight, and those protocols had to be modified. We modified the protocols, and then this modified protocols had to be disseminated. So emails were dispensed to all the staff on a continuous basis. So this whole thing was an ongoing process. On a daily basis, we had to update ourselves as to what are the protocols that were in place at that point in time. And this went on changing for quite a period of time. Then the problem came of testing. So initially it was RT-PCR, there were restrictions as to who is to be tested. Then it became open. So anybody who wants to get tested will go and get tested. So initially we had lesser number of people who were being sent from the flu clinic for RT-PCR testing. Then as it became open, the number of people who wanted to get RT-PCR testing became huge. And the initial arrangements did no longer were functional. So with the help of certain NGOs and so forth, we established booths which are outside the hospital, in the courtyard of the hospital, so that exposure was limited and there was place for people to form queues with social distancing. And these became quite popular. We had 3 booths running at the same time, and that was the way we were able to manage RT-PCR testing. The coordinator was handling the self-reporting forms, the SRFs, not SRS, sorry, the SRFs got swamped. So we had to give additional staff. We had to train a couple of students and volunteers as to how to fill in the SRFs and manage this large crowd in the initial stages. Waste management has already been described by Dr. Rupa was a hassle. There was a large amount of waste that was being generated, PPEs and so forth. COVID-specific protocols, which have already been explained, were needed for the waste disposal. And we had to have an additional segregation facility for the separating out the COVID waste. So protocols were put in place for the staff who were handling the waste as well. It's not just a question of segregating the waste and taking out the waste. We had to put in protocols for the staff as to what should they do when they are handling this COVID waste, how should they handle the COVID waste. We had to retrain them on how to handle COVID waste as opposed to general waste. The volume of waste was very large. In the initial stages at least, it was quite humongous, still is, and this was quite a challenge as far as the management of the waste was concerned. So that was the initial stage. Then after this, we went into a stage where we were kind of compliant. The protocols stopped changing. Staff was quite comfortable with what we were doing. We didn't have much of an outpatient load. The testing rates came, the number of patients coming for testing came down, number of patients in the flu clinic came down. Everything went into a kind of a homeostasis phase. And then we come to the current scenario where I call it a pandemic fatigue. We have been sitting with this for months now. Nobody knows where the end is. And everybody has decided that, it's there for such a long time, nothing's going to happen to me. If nothing happened to me for so long, nothing's going to happen to me in future. It's always that, you feel that an accident is going to happen to somebody else. Somebody else is going to get cancer. Somebody else is going to have a heart attack. It's not me. So that happened when the pandemic fatigue. People decided that it's no longer necessary to be as careful as they were before. So regulations were now started to be given a go by, and many restrictions have been thought as unnecessary. Initially, what we did was, we did social distancing. We pushed people away and said, go away, I want to keep a distance from you. But that changed. And now what we have is the opposite. We have people coming back together. You have crowds. You have 3 people on motorcycles. You have people whose masks are around their chin or on top of their head. So restrictions are going away now. And the initial phase of fear has given way to a stage of complacency. Restricting visitors to the hospital now has become problematic, leading to multiple confrontations with security staff. We have the security people standing outside checking temperatures before allowing people to come in. But you know how it happens with the malls. They either check the temperature on the back of your hand or maybe on the sole of your foot or something. And I'm sure that 90% of those thermometers don't work. And anyway, the security staff doesn't look at the number. He just points it at some part of your anatomy and then tells you to go in. The hand sanitizers have been replaced by foot-operated sanitizers, which dispense something which looks like colored water. So the whole system has become complacent now. We've had difficulty restricting visitors. There were lots of arguments with patients and security staff at the entrance. we had to retrain the secondary staff on how to handle these aggressive patients without worsening the situation. And COVID wall protocols needed much more stringent supervision to prevent it from going into laxity. So though we were trying, the curve started becoming flatter, we were scared that it is not going to last. There were problems of burnout, especially in the intensive care area. So the waste segregation became a little haphazard. It was not as clear as it was in the initial phases. So this put an additional pressure on the housekeeping staff as to how to segregate the waste as well as take it out and so forth. So we had to strengthen our support staff. Apart from strengthening the doctors, which probably is a different story as to how the director handled the situation of burnout in the doctors, but from our side, we had to center the support staff and ensure that the waste segregation, waste removal, sanitizing went on exactly as it was before the complacency set in. The amount of waste generated was still very high, and waste disposal protocols had to be maintained at the same level, though other protocols were sometimes being relaxed. So this became a bit of a challenge because we had to have the same amount of pressure on the waste segregation when other protocols were being relaxed. And that kind of created a little bit of a bad feeling with the guys who were handling the waste. So the pandemic seems to be far from over. We expect new challenges to be thrown up as time goes on because the laxity in the general population has gone up. We know that there have been huge second waves in the UK, there's been a second wave in Delhi. So, excuse me, we need to be prepared for a possible second wave and for a regression to our initial phase of where we had to handle a large number of patients. Maintaining the same level of commitment to protocols is going to become increasingly difficult because people are going to burn out. Once you keep putting pressure on them, they are going to burn out, and it's going to become increasingly difficult to maintain the same level of commitment. As has already been said, hand washing has always been a problem, especially among the doctors. And in the initial phases of the pandemic, we thought that it's going to become 100%. It didn't, it went up, but it didn't really become 100%. What we have to be careful now is to see that it doesn't go down again to somewhere around 50-60%. So my boss always used to say, when the going gets tough, the tough get going. So if the going is going to get tougher for the HICC, we have to be geared to get going as and when the problems arise. This is the mantra that we have taken up in the HICC. Seeing as how no end is in sight, we have to keep our morale up and we have to keep our commitment at the same time. So it's important for us not to lose steam as far as the infection control is concerned. Thank you very much. And I hope that I have managed to solve whatever I was asked to solve.
Thank you, Ravi sir, for your wonderful talk on infection prevention and control in COVID-19, practical issues in the hospital. Our next speaker, our next distinguished speaker is Dr. Lalu Joseph, who will be delivering her talk on standard precaution. Dr. Lalu is currently the quality manager and the accreditation coordinator at CMC Vellore. Prior to joining healthcare, Madam was a teaching assistant at Rotman School of Management at Toronto. She is a passionate teacher as well as a trainer and is involved in training quality implementations across the country through NABH, KAO, and AHPI, and is also a faculty of many hospital administration programs. She is the principal assessor of NABH and is currently the Secretary General of KAO India. She has developed 12 programs for KAO, but the basic and advanced certificate professionals for quality implementation in hospitals are well sought of. Madam, over to you for your talk.
Thank you very much, Divya, and thank you, Colonel Dayanand sir, for this opportunity given to me. I will keep it short. I think all about standard precautions has already been addressed. Let me straight away go to the presentation. Is it seen, Divya? My slides are seen?
Yes, ma'am. We can see your slides. We can as well hear you.
Thank you. Thank you so much for that. I have a lot of my friends here, all of them in the panel, Dr. JJ, Sanjeev sir, all of them. And I feel a little anxious talking about infection control and prevention in front of all the experts. However, the topic assigned to me is quite straightforward and most of those have been addressed. So let me straight away begin by saying what is this universal precaution versus standard precaution. Universal precaution, all of us know, it refers to the concept that all blood and body fluids should be treated as infectious because patients with bloodborne infections can be asymptomatic. So this is the concept that came into picture in 1980s when HIV was very prevalent, and to treat any blood and body fluid as a precautionary measure irrespective of whether a patient is symptomatic or asymptomatic. Now, in 1996, CDC changed the term to standard precautions, which integrated and expanded the elements of universal precaution to include contact with all body fluids except sweat, regardless of whether blood is present or not. So now the definition of standard precautions is very straightforward. Standard precautions are the minimum infection prevention practices. So we have to take that into consideration. It is the minimum infection prevention practices that apply to all patient care regardless of suspected or confirmed infection status of the patient in any setting where healthcare is delivered. These practices are designed to protect both healthcare workers and prevent healthcare workers from spreading infections among patients. I think that's the most important thing to note. To protect the healthcare workers and also to prevent healthcare workers from spreading infections among patients. So that's the crux of this entire standard precautions that we are going to be talking about. Now, WHO has clearly spelled out the basic standard precautions that one needs to undertake. Hand hygiene, hand hygiene, hand hygiene. I think all speakers touched upon hand hygiene. Then you talk about the personal protective equipment, which we say PPE, the standard precautions and the safe injection practices, clean patient care equipment, environmental cleaning, linen and laundry management, safe disposal of biomedical waste. By this using this term BMW, the BMW owners are a little apprehensive now because in healthcare BMW is biomedical waste. And imagine the owner of a BMW, it's become kind of a stigma, I feel now. And the final thing is the patient placement. Let's go one by one. Hand hygiene. Now, this is the most important component of standard precaution of any infection control activity. So it could be both ways, hand washing and hand rubs, using hand rubs. So when should one go in for hand washing? Visibly soiled hands or after they finished a procedure, and if they think the hands are contaminated, one should go for hand washing. Now, hand rubbing, yes, alcohol-based hand rubs should be available in plenty so that it is available in front of the healthcare worker as and when they need to use. Now, look at this. We keep talking about the 5 moments of hand hygiene: before touching a patient, before any clean aseptic procedure, after any body fluid exposure, after touching a patient, and after touching patient surroundings. Sir talked nicely about the various steps and how deficiencies are noticed. Yes, everywhere, step 5 is often ignored. And of course, step 1 and 2 are related to passing on the infection to the patient. Now, the healthcare worker could have his hands dirty. Now, when he's touching the patient, step 1, if he doesn't do before touching a patient or before performing a clean or an aseptic procedure, he is exposing the patient at risk. Step 3 and 4, which is, it's not step, it is situation 3 and 4, after body fluid exposure or after touching a patient, if the person is not performing hand hygiene, he is exposing himself at risk. So those are the two main aspects one has to consider. I don't think many of us are teaching the doctors and nurses the right way. We say these are the 5 situations, But why is it so important? 1, 2, 3, and 4. Once somebody knows that in detail, I think the intent will be better, is my own understanding. Now, also, it is not just telling people have, your hand hygiene practices are poor, people are not washing hands, people are not doing this, but you have to make sure it is available for them. I go for audits all over the country and I notice that the hand wash is inside the general ward bathroom. Imagine the doctors and nurses who have to go there to wash their hands. So, what is most important is to have them available when they really need it. So, therefore, from the design perspective, you need to have the hand washing sinks separate from the patient use sinks. So, if you go into your general ward, I would encourage all of you to go to their wards and see. The patient use sink where they throw away the sambar and wash their plates are the ones that are used for hand washing as well. So do not do that. Have a separate dedicated sink which is visible to the healthcare worker as and when he wants to wash his hands. Hand washing sink placement near the point of care, not too far away. That will be a deterrent. Easily visible within the 180-degree field of vision and height of the rim about 85 to 110 centimeter from the ground. Either it is too high or too low. If it is too low, it is going to splash. If it is too high, you can imagine what will happen. Adequate depth and size to minimize the splashing again. So there is a design factor that is attached to it. Not every wash basin can be kept there and say go and wash your hands, because that is going to cause splashing. And imagine wetting, you wet your shirt and pants and walk around. Nobody wants to do that. So that could be a deterrent for hand washing. Material, preferable porcelain, stainless steel or solid surface, because then you can clean them well. Otherwise that also will have black patches. Choose paper towel and avoid warm air dryers to prevent dispersion of bacteria. Alcohol based hand rubs available in plenty, to be made available as you enter the room, every bed. Some of the healthcare workers even carry it along with them as they go for rounds. That's again a good practice probably. Evaluate the location of soap and glove dispensers at the hand hygiene sink during the design. Ensure adequate space for waste containers near the sink. So these points are things that one must remember while they are designing. Designing is not easy. You have to put in your thoughts into why one would require all these. Now let's move on to the personal protective equipment. We don't have to talk about it at all. After COVID, I think everybody wants everything, irrespective of the risk stratification at all. Our administrators inside the cubicle who are actually probably just dispensing pharmacists require everything, because it's a fear factor. Now that is where what Dr. JJ comes into picture. The risk stratification: low risk, high risk, medium risk. What is required where? Of course, a person who's walking into a COVID ward requires everything. He's almost wrapped in plastic, I should say. It has reached a stage that you just can't identify the person who's working, whether it's a doctor, nurse, or a housekeeping. All our housekeeping staff are very happy because now you can't distinguish anybody. And the guys are very smart. Everybody looks alike thanks to COVID. So now here the risk stratification comes into picture. You need to ascertain what is required where, depending on the procedure or the area that they are working on. So this is about the personal protective equipment. There are certain questions asked in the chat box. I noticed what type of 3M mask is good enough. There are beautiful guidelines available. I will touch upon that a little later. Now coming to the third thing, which is the sharp precaution. Healthcare workers will have to be extremely cautious about handling the sharps. Now, the problem is, we in medical colleges, we notice often that when the interns come and join or the postgraduates come and join, there is a surge in the needle stick injury numbers. Why? Because of lack of proper training to them, and you can expect that the numbers are going to go up. Now, most hospitals have moved on to vacutainers, but still you will notice that our professionals are using the syringe to draw blood. Then what do? They poke the vacutainer and then pour the blood into the vacutainer. Imagine the risk factor. First, they're drawing the blood. Second thing, they're poking the vacutainer and they're pumping the blood inside the vacutainer. So 2 times the risk of what otherwise would be just 1 time using a vacutainer to draw the blood. So you have to teach them the techniques, and often it is because of recapping of needles. So the issue is, how should one recap? Is there a need for recapping at all? So those are the things that need to be taught, and improper segregation of waste. It's pathetic to see our housekeeping staff acquiring needle stick injury because the sharps are put inside the waste bins. So all these are not acceptable. We need to make sure that we are protecting our healthcare workers by giving adequate training, giving them measures. They may not know. Young children, interns coming into the system, young nurses just coming into the system may not know the problems, that one would put them at themselves at the risk that they are exposing them to. So you will need to be extremely cautious about this standard precaution on sharp needle stick injury protection prevention. The other thing which is often ignored is clean patient care equipment. Now, how to clean these equipment, what chemical to use, what is the frequency of chemical. So we need to make sure that the equipment are handled properly. Now, if you're going to use the same, hypochlorite to clean these equipment, you can imagine within no time the equipment is going to, the material is going to get spoiled. So you need to identify the surface, what chemical to use, how to use, what is the frequency of cleaning the equipment, when to clean, and also who's responsible for cleaning these. Often that is left as a no man's land. We call it in healthcare, there are many, many no man's land. Everybody thinks work is happening, but in reality, many things are not happening. So this is one danger point. We need to make sure that our equipment are kept clean, particularly if they are soiled with blood and body fluids. So we tend to take care of those that are soiled with blood and body fluids, but ignore those heavy equipment like CT and MRI. Those gantry also need to be cleaned frequently and periodically. Now, reusable equipment, we are careful. Items, because the CSSD process comes into picture, we clean them, wash them, disinfect them, and then send for sterilization. Environmental cleaning. Now with COVID, cleaning, and cleaning. Now our lifts are all corroded because it is 1% hypochlorite that is used in the lifts. So what happens? Your surface is also getting corroded. I should say thanks to COVID again, because we at least have a proper protocol established now for cleaning the system, the hospital, the facilities, the fomites, the fixtures, everything. Now, environmental cleaning, again, the proper technique is needed. You have to train your housekeeping staff. The frequency of cleaning has to be ascertained, and the right chemical in the right mix is what is needed. Now, when we go for assessments, we notice that we tell them 5 ml of the whatever chemical to be mixed with 5 liters of water. Now, you ask the housekeeping staff, how do you know the ratio? They'll say, yes, Amma, 5 ml of chemical. How do you pour? They just pour like that. They say, yeah, we know this much will be 5 ml. And that would have been 50 ml poured into the 5 liters of water. They will not have a small measuring cup also. They will not exactly know what to do. This is where supervision comes into picture. Right chemical, right mix, the right timing, the right frequency, the right technique. This is science. We often ignore housekeeping. But please understand, housekeeping is one of the most important aspects of standard precaution, infection prevention, and control. Clean linen and laundry. You ask most of the hospitals, when you go to, you ask them, how do you categorize your linen? Infected linen, not infected linen. That's not how we categorize. All in linen are considered to be infected linen. However, you need to segregate them based on whether they are soiled or not soiled. Soiled linen will have to be pre-treated before you are washing them. Not soiled linen, unsoiled linen, you could wash them directly. Now, the process of washing, the temperature to maintain, the chemicals to use, everything varies from the type of linen and the level of disinfection that is required. Also, closed containers to be used, how to collect, counting, all that for administrative purposes, transporting them, processing them, storing them, moving them, because this is another aspect that you will need to consider for proper infection prevention aspects. Madam would have discussed, I'm sure I was not part of the discussion, about the safe disposal of biomedical waste. This is a huge problem, particularly with COVID. The quantum of waste has doubled now. We used to generate about 3 tons of waste and now in a day, and now it has gone up to over 6 tons a day. We admit about 950 COVID patients. Now it's come down to 200. We're just keeping our fingers crossed that it doesn't increase. But this is a huge challenge in healthcare organizations, particularly in small hospitals, where, in one of the assessments that I did, the senior doctor was standing there and removing the sutures of a patient. He put everything in a kidney tray. And I noticed this, and then I noticed that the biomedical waste segregation in that hospital was really bad. Then he happened to be the owner of the hospital. So I asked him, sir, there is a problem. What do you think should be done? He said, madam, I'm very upset with my IMA. How many times to train my IMA? So I said, sir, IMA is not the one who was actually segregating the waste. You know what was happening? Everybody puts the waste in the kidney trays. And this poor IMA goes with that kidney tray near the bins, yellow waste, red waste, sharps, so it became her duty to segregate the waste. That is a very wrong practice, and often in hospitals we see this happening. So I like this picture where this kidney tray is taken and somebody is standing there and segregating. That is a wrong thing to do. Proper segregation, collection, transportation, storage in the temporary storage area, appropriate PPE to be provided to the staff. Even if you provide, these guys don't use them. That is another big problem. Rubber gloves you give them, they say, I'm sweating, I can't use it. So where do you put a stop to all this? Nobody knows. Now then they come with a needle stick injury and they say, your doctors are not segregating properly and I have got a needle stick injury. If only they had worn the rubber glove, I'm sure they would not have got. So it's a situation where you really can't blame anybody. Everybody has to do their job properly. Appropriate PPE and also the vaccination of the staff handling the biomedical waste. Respiratory hygiene, cough etiquette, placement of patients. I'm sure all these airborne precaution, contact, droplet would have been talked about in great detail. But today, all of us are going through this. I hope a time will come when we can really remove our mask and walk freely. Can't imagine, I've been asking our purchase committee chairman, at least give us some different color mask. Every time wearing this blue mask is really creating, it's a stress factor, I feel. At least some yellow color, green color, depending on what you will wear for to the hospital, some color change. But yes, what to do? We are going through this. We need to be very, very careful about placing the patients, the cough etiquette. One should educate the patients. Persons with respiratory symptoms should apply source control measures, wear appropriate masks, place them 1 meter or 3 feet away in common areas, particularly in OPDs, which is often not possible also because crowded OPDs. Visual alerts at the entrance of healthcare facilities instructing patients with respiratory symptoms to practice hygiene, respiratory hygiene, and cough etiquette. Make hand hygiene resources, tissues, masks available in common areas and areas used for the evaluation of patients with respiratory illness. I think this is something that is, again, thanks to COVID, it has come into picture. Most of our hospitals today have hand wash facility with good soap available. You have masks that are provided to the patients. You have some social distancing maintained in the OPD and other areas. Don't know whether it will continue for long, but at least this cough etiquette, the whole world is now tuned to some aspects of cough etiquette and how to cough, how to sneeze, all that. Some education has come in definitely with COVID. So with this, I would stress upon this. To be in charge is certainly not only to carry out the proper measures yourselves, but to see that everyone else does that so too. This is from Florence Nightingale. We as managers, administrators, departmental leaders, nursing in charges, or our own area supervisors, we have a huge role. We have to be taking the measure, first and foremost, to be an example and also to make sure that others follow. So we need to be very careful with all these measures because it is not just one person, it is a huge number of people that we are impacting. Our own healthcare workers' safety and also the safety of the patients we treat. So we need to put in 100% efforts into making workplace safety a priority, not just for us, for our own healthcare workers, but for the patients who are coming into our system. Thank you very much for this wonderful opportunity provided.
Thank you, madam, for your very informative talk on standard precautions. Due to the paucity of time, if there are any questions, we request all the panelists to send across, all the participants to send across your questions so that it will be answered. Dayananda sir, would you like to add and conclude something on the isolation precautions, sir? Sir, kindly unmute yourself, sir.
Am I audible now?
Yes, sir.
Firstly, I would like to profusely thank all the panelists, eminent panelists, and the most important part is all are practicing infection control, this thing in their various areas and contributed hugely to infection control, starting from Dr. Sanjeev Singh, Dr. Vandana, Dr. Chiranjoy, Lalu Joseph. Of course, she's a very passionate this thing on the infection control in all the forums that I heard in the last few years. She emphasizes on this part. I think it needs emphasis because we have not reached that level in spite of all our efforts. We have not yet reached the level of infection control that is required. Just rightly from the pointed out by Chiranjay that the clinicians first and the other healthcare workers, in spite of all these, in spite of the COVID situation also, we have not really gone into the first basic of this thing as a hand hygiene. However, all the points were very beautifully spelled out, and also Dr. Jayalakshmi and Dr. Rupa also. Thank you so much for all this quick response to our request and having come over. And it is a wonderful session, probably much better than a well-organized conference, I mean to say. So because of the time constraint, probably we'll avoid this, we'll forego this panel discussion. However, thank you very much again to all of you. Thank you.
Thank you, sir, for your concluding remarks. I request Dr. Sujay to propose a vote of thanks.
Thank you, Dr. Divya. I consider it a great privilege to propose the vote of thanks to all the dignitaries who have made this a successful event. I, Dr. Sujay MJ, on behalf of Department of Health Systems Management Studies, extend my pranams to His Holiness Jagadguru Sri Shivaratri Deshikendra Mahaswamiji. I extend my heartfelt thanks to our Pro-Chancellor, Dr. B. Suresh, for his support, vision, and commitment. I extend my heartiest thanks to our Vice-Chancellor, Dr. Surinder Singh, for his leadership and support. I take this opportunity to express my deep gratitude to our Registrar, Dr. B. Manjunatha, for his constant support. My heartfelt thanks to Dr. P. Kushalappa, Director Academics, for his guidance and support. My sincere thanks to Dr. Colonel Dayananda, Director, JSS Hospital, and Dean, Department of Health System Management Studies, for his constant mentoring and supporting us in all our endeavors. My heartfelt thanks to all the resource persons for sharing their valuable knowledge and providing information to all of us. I thank Dr. Ravindra, CEO, and IT team, JSSAHER, for their support in successfully organizing this webinar. I thank Dr. Mamta HK for her support in conducting this program. I thank all my colleagues and participants for their support in making this event successful. And finally, I thank one and all for directly and indirectly supporting this program. Thank you.
Thank you.
Thank you, Dr. Sujay.
Thank you, madam.
Thank you all the panelists once again for responding to our request at a very short notice and making this event a successful one. Thank you, Lalu madam. Thank you, Jayalakshmi madam. Thank you, Dr. Rupa. Thank you, Vandana madam. Thank you, Dr. Chiranjay. Thank you, Ravindra sir. And I also thank my colleagues once again for extending their support in carrying out. Dayananda sir, without you, it would not have been possible. Thank you, sir.
And thanks to Dr. Divya for coordinating with all the resource persons, collecting the information, and for the excellent communication she has been having with the resource person. Thanks to Dr. Divya too.